All right, good morning, everyone. Good morning. Thank you for facing the weather today. We're really excited to be back in person. My name is Naomi McLeod. I've met several of you on Zoom, webinars, emails, calls, but I'm really excited to be back in person to have our first conference since 2019. It is now my pleasure to introduce Dr. Rajan. Dr. Rajan is a board-certified fellowship-trained neurologist specializing in movement disorders such as Parkinson's disease, essential tremors, dystonias, tics, Huntington disease, and Tourette syndrome. He is experienced in managing deep brain stimulation selection and programming, as well as Botox injections for neurological disorders and nerve blocks of the head and neck. In addition to movement disorders, Dr. Rajan has a special interest in ataxia, as well as Alzheimer's dementia, primary progressive aphasia, and other neurodegenerative disorders. After completing medical school in India, Dr. Rajan earned his Master of Science in Clinical Neurology and subsequent research fellowship from the UCL Queen Square Institute of Neurology in London. Following an internship with the University of Missouri, he completed his residency at the Wright State University before pursuing subspecialty fellowship and training in movement disorders at Johns Hopkins University. He is currently also serves as an adjunct assistant professor in neurology with Johns Hopkins University. He is certified by the American Board of Psychiatry and Neurology. Dr. Rajan enjoys the long-term relationships that he forges with his patients as he helps them navigate their disorders over time. His goals are to combine bedside diagnostic skills with advanced testing and therapeutics centered on each patient's need. He believes healthcare is a team effort shaped by each patient's need. As new discoveries and novel treatments emerge, he believes it is exciting to see how diseases in his field are recast. Please welcome Dr. Rajan.
Can everyone hear me well? All right. Is this a mic we're gonna circulate around for the questions?
Yes.
Okay. Gotcha. I might use this for kind of moving around. All right, so my topic today is about levodopa. This was chosen mostly because there is a lot of fear of levodopa among the Parkinson's disease community, both patients and doctors. So there's a little bit of a history behind that fear. So I wanted to just kind of address that. And then obviously we have a 5-minute, 10-minute at the end where we can, go over some questions that you have. All right, so just to kind of walk you through the mechanics of dopamine and what happens in Parkinson's disease with this. Okay, so this is a side view of the brain. You slice it open right like that, and then your nose is actually on the on this side of the screen, as you can see, and then your back of the head will be here. You're seeing the cerebellum here, which is a little brain in the back of the brain, which controls balance. Right in the middle is the brain stem here. This is roughly where the thalamus is, and this is the basal ganglia system, roughly around here. That is where most of the action happens in Parkinson's disease, or, no pun intended, lack of action, right? Roughly around here, where these little globules are marked here, and that is where your subthalamic nucleus is. And about here to here is where most of the destruction of cells in Parkinson's disease that causes loss of this vital chemical dopamine happens. The cluster of little bubbles here that denote the location where all these cells sit and send their signals all the way around the brain. And again, remember, you have 100 billion neurons in the brain, about 70 to 100 billion, some of us probably less, but more or less 70 to 100 billion. So each cell has 10,000 or so connections. The lines here are just a representation of that, just a representation. You can imagine millions and millions of connections spreading. Pretty much they look in real life under the microscope, they look like how the roots of a bunch of grasses when you pull it out of the root, pull it out of the ground. So they kind of spread all over the brain, giving the rest of the brain signals to move, signals to, coordinate movements and steady your movements, and also give your muscles a tone meaning a tightness that the muscles need at the baseline to start acting. Okay. And what happens in Parkinson's disease, and this is an extremely simplified version, by the way, there are a lot of other models that are being used or other explanations we have to explain tremor, explain slowness, explain extra movements that happen with levodopa, and explain balance problems. Okay, so there are different models and different explanations for each of these symptoms. This is the simplified model for just why Parkinson's disease patients are slow or stiff. What happens, and again, I didn't mention one of those things, so let me just talk about that a little bit. These signals generally tend to have two purposes. One is if I want to hold on to something or grab onto something, my brain decides to actually do this, and my basal ganglia, which is about here, all of this structure here, it decides to actually tell the muscles to move, but in a very coordinated manner. So in order to grasp something, it has to actually make sure these muscles are, flexed, whereas some of the other muscles need to relax and then move that and make that movement, right? So there is a acceleration process where you put the, put on the gas pedal for the brain to start doing this. And there is also a brake. So it has to reach out and then stop where it should be. And imagine all of this is actually for every bit of your movement. So I do not want to actually go too far or go like that or go less. I need to go exactly this, right? That little, sort of that fine motor coordination requires a little bit of a brake and an accelerator action, right? So when the structure, the nigrostriatal system comes from the word substantia nigra, which is Latin for dark substance, and striatum, which is actually a part of the basal ganglia. So the substantia nigra here and the basal ganglia talk to each other through this branching, nerve cells. So when this part of the brain or these cells start slowing down, or sometimes they die off because of the pathology that happens in Parkinson's disease brains, the brake system becomes a little too active. So the movements are slowed down by both a reduction in the accelerator system, which is what I show here in the point number 3 here. So reduced action of the brake of the accelerator system and increased action of the brake system. Together, this makes Parkinson patients move slow. This is again a simplified movement. Overall, this is the reason what we think is going on behind the slowness of Parkinson's disease patients. And predominantly, this system talks to each other, or these cells talk to each other with the chemical dopamine. Okay, and that is the story of today's talk, actually. What is dopamine and how is levodopa converted into dopamine, and what is going to happen with the brain when it gets too much levodopa, and why should we fear levodopa and why should we love levodopa? All right. So dopamine system is very, very vital in Parkinson's disease patients because of this action. Again, this does not explain why tremors happen. There's a little bit of, there are some activities that happen here that would explain tremors, but not all symptoms of Parkinson's disease are explained by dopamine alone. There are other chemicals like serotonin, acetylcholine, a bunch of other chemicals actually, norepinephrine, epinephrine. These are all chemicals that play in this role. And imagine dopamine is only one chemical that is derived and is in the pathway in which all these chemicals are made. So some of these chemicals are made into serotonin. Some of these chemicals are converted into dopamine. Some of them are converted into norepinephrine, some of them into epinephrine, or they're the same as adrenaline and noradrenaline. So these are all little proteins that are made from a basic protein, structure. So imagine, we call them amines, actually. So dopamine is only one amine. All right, so just a little bit of history. I'm not going to go too deep into it because we want to get to the other major part of the talk. So Ole Hornykevich, actually, He is actually the scientist, he was a physician, but scientist as well, a pharmacist by training, who showed that low dopamine in Parkinson's disease brains actually probably are the reason for them slowing down. Arvid Carlson, a Swedish scientist actually who worked in the United States, all of them actually worked in different parts of Europe, but ended up in the United States actually doing a lot of research at NIH. He showed that these little rabbits, when you give a chemical called reserpine, which is actually a chemical from a plant called Sarpagantha, pretty much the name sounds like ashwagandha. They're very similar in the Ayurvedic tradition, or used in very similar diseases. When you give reserpine, a chemical from that plant, to rabbits, they become paralyzed. They look like Parkinson's disease patients. So this chemical was used around the world by different scientists to create animal models that look like Parkinson's disease patients, to train or learn how different chemicals change that. So when you give this chemical levodopa to these rabbits, you can see the ones that were droopy in the first picture, they are perked up. So that was one of the, that picture is one of those iconic pictures in medicine that actually changed the world, to be honest. So if you are looking for like pictures that change the world, the DNA loop, the atom bomb, and probably this picture would probably come at the top of the 10 pictures, I guess. So he actually showed this. It's not just one picture that changed the world's mind. He went around the country giving talks about how dopamine actually changes this, and then went on to develop a method to measure dopamine in the brain. These two physicians, George Kotzias and Melvin Yar, they both actually started the clinical trials of levodopa. So they went ahead, and again, these happened in the dopamine, or the chemical structure dopamine was identified around 1911. It took almost 30 years again to actually identify levodopa as a chemical and then start, these trials. 1960s is when actually it started becoming a big chemical in the medicine world. So you can imagine this is a very slow process. A lot of people work. These are representative people who stand at front, and then Arvid Carlson actually got Nobel Prize, Kotzias and Melvin Yar as well, but Hornikiewicz was actually overlooked. That's a different politics. But anyways, levodopa was confirmed as the chemical that actually can improve a lot of symptoms of Parkinson's disease by Kotzias's trials and Melvin Yar's trials. These happened in the 1970s. So by 1980s, we knew that this is actually a good chemical to try in Parkinson's patients. Now, most of you guys who are on levodopa know how nauseating it can be, how dizzy it can be when you take it for the first time. You get used to it after a while, but a lot of people don't. I have a lot of patients who don't still get used to the nausea that comes with it, right? So the early scientists actually took it themselves and threw up. So it wasn't like they started giving it to patients. They actually knew this was nauseating. In fact, a lot of the old patients in the early 1900s actually got tubes put in their nose to actually let them take it, because they couldn't take it by mouth and then let it sit in their bellies. It would just make them throw up. So they even had to put in tubes in them to actually give them these large doses. And they noticed that you need higher and higher doses for this to actually work for a lot of these patients. Initially, they knew when they gave these chemicals to animals, it perked them up for a little bit, and then they went back to the old droopy state. So we knew that this was being destroyed very quickly in the bellies or in the brains of the patients, or animals first. And then we knew that was happening to the patients as well. So it didn't really last long enough, right? So it's something that you have noticed as well. You need to take it 3 or 4 times, sometimes even way more than that. So we knew all of that way back in the 1930s and 40s. And then by 1960s, we were designing chemicals to make it last longer. So Bartolini and team in 1963 found that this chemical Rho 44602, again, all chemicals are given a code name, pretty much like the Manhattan Project first before we actually name it. So these are like, church names that you keep secret until they baptize them, right? So basically, before the baptism, they actually gave it, and then they found that it was actually better with helping levodopa get into the brain. And we found that there were chemicals in the body that would destroy levodopa, and make it like, products, and this will be excreted in the urine. So most of levodopa goes through liver and urine, so kidney. Most of it goes through the kidney. So if you have good kidneys, your levodopa should work fine, but you pee it out pretty much quickly. Within a matter of an hour of 40 to 60 minutes, you're basically peeing out the levodopa that you already took. So they designed this chemical or this molecule and found that it was actually preventing the destruction of this levodopa in the body. And again, separately, Coetzee and his team found that this chemical called alpha-methyl dopahydrazine, long names, in 1968 did the same thing as well. So they actually these chemicals seem to either die in the body so that levodopa can live. So that's what we call it, we call it like suicidal inhibitor. So the way we designed this chemical so that they actually can be destroyed by the chemicals that destroy levodopa, so that levodopa can live, get to the, get through the gut into the brain and work, right? So these two chemicals became known as carbidopa and benzoyl. So this is why alpha-methyl dopahydrazine is still in your medication, right? Your levodopa has its friend called carbidopa. So carbidopa is its roommate that actually dies for levodopa, so levodopa can live and get in their brain. Benzoyl is not popular in the United States. It is actually very popular in Europe and UK. So if you are from somewhere there, or even Canada, you might have heard of, Prolopa, or the other one is called Metapar. So these are all names for brands of, these combinations. So both of them, benzoyl and levodopa, or carbidopa and levodopa, are marketed around the world as Sinemet, Metapar, or Prolopa. There are other Caraldopa. There are a bunch of other, dopamine names there. So they were all brought out by different companies after that. Now it's generic. It's been around since the 1960s. So if you are paying out of pocket, it usually should not cost more than about $12 or $10. Even that is high, I would say. But talk to your, congressman about that. I don't know. I don't have the power to change that. All right. So levodopa, what does it help with? As I mentioned, it doesn't cover all of the symptoms. But when you have just been diagnosed with Parkinson's disease, my way of doing this is I'll start with a slow dose, a low dose, and gradually build it up, right? I want my patients to kind of feel the effect of it for the first month at a small dose, or maybe first few weeks at a small dose, and then build it up gradually. Once you get to a bigger dose, you'll feel the effects more prominently. So again, we're changing brain chemicals here. The brain is it's an organ that is set in its ways. We all know that, right? It takes a lot of time to change our habits. Just like that, these nerve cells take a while to really adapt to the cycle, right? So if you're taking it 3 times or 4 times a day, your body needs to expect it that way. It needs to prepare the receptors for these dopamine chemicals coming in. It needs to prepare the storage capacity. Basically, this is like you have, a party going on. You know that you'll have a lot of leftovers. So you call up your friends and tell them, hey, empty out your fridge. We'll have a lot of leftovers. You need a lot of this stuff to be. So you want to prepare their fridges because you're going to have a lot of leftovers that you need to take over, right? So this is basically what's happening in your brain. So when you're getting levodopa, it is stored in vesicles in the brain to be used later, especially in the early part of the disease, the first 5 or 6 years of that disease, right? So you need your brain to be trained about this. So this is why I started very slowly and tell the patients, I'll usually give a list of symptoms to look for, right? These are the classic ones that I expect to improve with levodopa. And again, they usually happen with most patients. If you don't feel the effect of levodopa changing anything like this on this list, don't be despair or don't despair. It is not because of your disease being very different. It's something else. We'll talk about that later. Slowness, which is what we call as bradykinesia, or slow. When I make my patients do these finger taps, you see them kind of tapping like that, and they have a little bit of a block. Or sometimes when they do this will be very slow. That's what we call bradykinesia. Then you have a stiffness. I ask them to move their hands around. I come sometimes, feel the movements, and you can see a little bit of a ratchetiness to the movements. This is because the muscles are told by the brain. Remember that brake system is a little too active. So the muscles are not moving smooth. There is a little bit of a stiffness there, right? Then you have tremors. Again, tremors can be from another mechanism as well. So it's not really always responsive to levodopa. Up to 70% of patients report that their tremors improve with levodopa. But about 30% of them, or even that within that 70%, a group says it doesn't take away all the tremor. That's because you have other parts of the brain that are involved in this as well. It's not just, levodopa playing the role in it, right? Postural changes. So you might have probably seen Parkinson's disease patients yourself or Parkinson's disease patients that you manage having a powered down robot kind of a stance, right? They are a little slowed down and then they have a little hunched posture. These things also, when after the levodopa, just like that rabbits perked up, you can see a little bit of a perking up. When they walk, they stand tall, their shoulders are a little wider as well. When they walk, you can see that as well. So the speed of walking is also improved. Instead of that shuffling gait, they might walk a little smoother. And I usually test this out. If I have a patient who doesn't respond to levodopa, tell me that, no, I don't feel anything different. I'll tell them, okay, your last dose is going to be on Friday. Don't take anything on the weekend. Come back on Monday. Let me check you out without the levodopa and see if any of these symptoms actually are really bad. Then I'll have them take the medication, wait them in our, have them wait in our infusion center or infusion room. Come back again and do it again and see if they actually have improved. I'll either, if they don't appreciate it, I'll get a video of it and show it and say, hey, look at that. You were the droopy rabbit, now you're a perked up rabbit running around, right? So you can see. Again, this is no, I'm not, disparaging the patients who don't appreciate the symptom change. It is normal for Parkinson patients to not appreciate it because basal ganglia is designed for automatic stuff. So the reason why I'm talking with my hands is because my basal ganglia is trained to do it. I don't even think about how I'm holding my hands or anything like that. I'm consciously not processing this. I'm just doing this because I have learned this from my parents or somebody else, right? Or my teachers. So this thing or the arm swing doesn't come, you don't have to consciously remember that. Naturally, you should have that arm swing, right? Or your random ticks, like if you have your leg on your, on the knee, you might probably, tick your leg or, jerk your leg or shake your leg. All of that is natural. You're, sometimes, sniffing, touching your face or putting your hands in your pocket. All of that is natural and normal, right? This is not consciously processed. So most of, our brain's processes are not consciously processed. We think we are completely in control of this body. Really, no. Can you feel your heartbeat? If you feel it, it's bad. Then we need to go to the ER. You can't feel your heart, right? You can feel your, bowels making, poop now. Again, if you feel it, yeah, tell me, okay? You can feel your, armpit sweating. So all of that is automatic and they're all unconsciously processed. The conscious part of you are listening to me now and looking around and feeling the scent and all that stuff, right? But again, the brain is not designed to do, reality. It's not designed to write poetry or paint pictures. It is designed to make you survive. So most of the brain is basically monitoring your bowels, monitoring your, belly, monitoring when you need to actually go to the bathroom, monitoring when you need to go talk to the, doctor about something else, that sort of stuff. So it is a survival machine that is monitoring internal, stuff and internal milieu, making sure that you're always comfortable around you. So it's not consciously feeling the tremor. It is not consciously feeling the stiffness. So if you don't feel the difference when you take the medication, then this is a good way to check. You stop the medicine again with your doctor's permission. Don't do that by yourself because Dr. Rajan at the meeting told me that, right? You need to talk to your doctor and see if you want to come off the medicine and see if it actually helps you. Okay. A lot of patients feel an upbeat mood after Parkinson's disease is treated with levodopa. They don't feel it right away, but after a while they feel, okay, if I miss a dose, or if I don't take a medication because I was at my golf game, or I was actually skiing or something else, or at a ball game or something, and then forgot the medicine, you can feel it in a way. Most patients cannot really tell me what you really feel, but you can feel it internally. That loss of that, something is bad, is usually improved by levodopa. So a lot of patients feel that their mood has improved. So a lot of patients with Parkinson's disease who have depression or apathy or low mood can actually respond to levodopa itself. They don't really need a depression medication sometimes. Excuse me. So that's what I mean by non-motor invisible symptoms. I've had patients who told me that their bladder is better. They have better control over their bladder after the first few doses of levodopa. They also feel like their bowels are moving better with levodopa. So even if we don't see objective evidence of this in measurements. We haven't measured everything in your human body, right? We still are learning a lot. So there might be a ton of things that we don't know. There might be a ton of things that levodopa is doing for an individual patient that we don't know. Okay, so there are a lot of invisible symptoms that we don't really appreciate, but if you appreciate it, I would say document it so you know if we are coming off of levodopa or wearing off of levodopa, are you actually experiencing that off effect the same way? All right, so just like I said, it's not a cure-all for Parkinson's disease. There's plenty of symptoms that require its own treatment. So why do we love to hate this drug? There's been a lot of, in the early 60s and 70s, as you just heard, all these scientists were using levodopa for themselves. They didn't have Parkinson's disease. They were just trying it out just to see if it actually makes them feel the same side effects, right? A lot of patients also complained that it was wearing off quickly. It was actually not working after a few doses. Some patients who were tracked for years, 2 years, Coatsias's patients and Melvin Yar's patients were tracked for 2 to 3 years. So their papers span from 1968 through 1977 or something. So they had 10 years worth of data with a lot of different patients. So a lot of these patients actually felt like it wasn't working anymore or wasn't working long enough. Again, they had other reasons, and again, the chemical they used, the type of levodopa they used were different as well, manufactured differently, impurities were there, plus they were also not using carbidopa as much, right? So there was a lot of fear among patients as well as clinicians that this is actually either making the disease worse or was not working at all. In fact, Ole Hornikiewicz actually wrote that this is in no way a perfect drug. Absolutely, yes, it is not a perfect drug at all. But this fear spilled into another fear when you started using this for 5-10 years. It was causing dyskinesias. A lot of you know that. When you take levodopa towards the end of the day or later in the afternoon, when you've had 3 or 4 doses. I was about to ask a little bit more. Thank you. Somebody actually heard me talk. So, a lot of patients, when they were actually feeling like later in the day, when we were taking these medications, they felt like it was actually giving them a whole host of, shaking and extra movements, right? So obviously these, extra movements that you were actually, getting were because of that accelerator effect I mentioned, right? So levodopa seems to give that extra dopamine in the brain, and that dopamine produces that accelerator effect as well as relieve the brake effect. So you have a whole host of movements. That is what dyskinesia is. So this made patients worry, and families as well as clinicians worry that are we making Parkinson's disease worse, or this was not seen at that time. Because remember, until 1950s or 60s, we didn't have levodopa. So Parkinson's disease patients basically lived for 2-3 years and then passed away because they were basically getting fixed, rigid, getting pneumonias, falling, and then eventually dying very soon. So we didn't really have a chemical that changed the course of the disease at all, right? So when we started making patients live longer, we were able to see these things happen. So now the question was, is levodopa causing something in the brain to go away? So there were some papers around this in the late 80s that suggest that levodopa might be causing what we call oxidative injury to the brain. There are some chemical processes through which levodopa goes that we have seen some free radicals, which means oxygen, O- radicals kind of float around in the blood. We've seen that in animal models and in the petri dish. So we thought this was happening in the brain, and levodopa was killing more brain cells. Eventually, what happened was there were a lot of countries in the world that didn't have levodopa, couldn't afford levodopa, especially countries in the continent of Africa. So we started using levodopa in the 90s in these countries where it became more affordable, right? And then we found that patients who were not taking levodopa at all for 5-7 years, who have gone through Parkinson's disease for 5-7 years, within a matter of a few months, they started having dyskinesia as well. So we found that this was not levodopa causing dyskinesia. It is just that their brains go through a process by which at some point levodopa works weirdly and makes you move a lot more. So it doesn't matter if you start levodopa early or late. Dyskinesia is going to happen when you get to that stage of the disease, right? So it wasn't dyskinesia just triggered by levodopa. It is the disease itself that uses levodopa in a particular way and causes dyskinesias. So there was another fear generated by pharmaceutical industry where there was a lot of research going on with levodopa-like medications. Okay, so we call them dopamine agonists. Some of you are on them probably. Requip or ropinirole, Mirapex or pramipexole. There's a patch called otigotine or Nupro, right? These are the three that we know here that we use. Then there are other medications that are in the cholinergic family, the Artane and triazephenidil. Then we have benztropine. A lot of patients with psychiatric, diseases who have Parkinson-like syndrome are on benztropine as well. So these are medicines that are using another or different mechanisms in the brain, not the same mechanisms as levodopa does. So if you are using those medicines, or if those medicines are being used, then you don't get dyskinesias that much. So we know that dopamine, extra stimulation from dopamine that is coming from levodopa is needed for dyskinesias. So a lot of doctors initially thought that maybe we shouldn't use levodopa in the first place. We should try something else first, and then try levodopa as the last resort. So this idea was in the 90s and early 2000s even, the idea was that levodopa is for somebody older than 70 who have gone through Parkinson's disease for 5 years or so. And then you can try levodopa, try something else before that, because you're going to cause side effects. Right? What we found for between 90s and the 2000s was these patients were getting worse very quickly because they didn't have the right medicine. They were slow, they were stiff, they had the shakes, they were actually falling a lot. Their quality of life was really bad. So that was the whole fear back then, that levodopa was making things worse. You should try something else. Now we know that quality of life doesn't improve. Levodopa is the one that actually improves quality of life. So by 2000s, we flipped. We said, no, everyone should be on levodopa as soon as possible, because that is the one medicine that seems to be improving the quality of life indirectly. It is giving you more smoothness of movements, improved ability to walk faster and exercise more, because obviously that part, the exercise and engaging in physical activity, seems to be the main thing that actually drives quality of life in Parkinson's disease. So if you want to get a medicine that actually makes you do all of that, engage in life as much as possible, then that is levodopa. None of the other ones seem to have that much of a quality of life improvement. So that is where we decided, American Academy of Neurology, in the last 3 years or so, have come up with position statements saying that, okay, neurologists, you got to get on board with this. We have to start levodopa as soon as possible, early. Okay. You should not be waiting for the 70 years and 5 years of disease. None of that criteria counts in. So we were trained, when we were training in the 2000s, we were trained, no, we start with levodopa. We can try other medicines if you need to, if you have a lot of other side effects of levodopa, yes. Or we want to play around with other medicines to kind of reduce the amount of levodopa you're giving. We can try all of that. But levodopa is the gold standard. It is the main thing to try. So just start with it. Okay. All right. Side effects. We don't want to, glorify levodopa without giving it a little bit of a bump there, right? So nausea is a main problem, okay? And drop in blood pressures, because levodopa can be converted to certain other chemicals that causes drop in blood pressure. In fact, a form of levodopa, methyldopa, is used in pregnancy where you have preeclampsia or eclampsia, very high blood pressures. You can use a type of levodopa that actually brings the blood pressures down. And dopamine itself is an infusion that cardiologists are very familiar with. We use it in the ICU to drop heart rate and drop blood pressures and control blood pressures very carefully, okay? So we do know that levodopa drops your blood pressure. And Parkinson's disease patients have a low blood pressure tendency already. So if you are already a Parkinson's disease patient with a low blood pressure or low heart rate, levodopa can make it a little worse. So that's why all my patients, I will carefully review their blood pressure medications and see where they're standing, and tell them, hey, get your blood pressures at home. If you're running low, I'm going to talk to your PCP. Let's drop that lisinopril that you're taking, or your amlodipine that you're taking, or some other medicine that you're on, right? So you take away your blood pressure medications first, increase your hydration. Thank you. And any electrolyte drinks, I would usually recommend 0-calorie Gatorade or any kind of Powerade or anything like that. That actually should improve your blood pressures. And again, if you're sitting there for a long time like this, you should be getting up and walking soon. I'll let you do that. So just kind of, get your circulation up so that your blood pressures are not constantly dropping, right? And there are other medicines we can try to actually increase your blood pressures. Again, those are things that we can try, but I would probably go for the most easiest thing. Get your blood pressure medications out, increase your hydration, natural mechanisms first, and then add a medicine if it is still not getting up there. Feeling spacey is a very common complaint of Parkinson's disease patients, feeling dizzy, especially after the first dose of levodopa in the mornings. So I usually tell them, if it is so severe that you cannot get out of the bed, take your levodopa, the first dose, in bed. Leave it at the counter or vanity table or whatnot, and take it first thing in the morning. Sleep a little bit. So wake up, if you're waking up at 6 a.m., just take that, wait in the bed for another 20 minutes until it kicks in. Your nausea and that feeling of spaciness is gone. Then get out of the bed and do your thing. Okay. Now, people have told me a lot that they see bugs in the periphery of their visual field when they're taking levodopa. So you can see little dots and moving black spots and things like that very often. If it is crawling on the floor, they might feel like it's a bug. So that is very common with Parkinson's disease, especially in the outer rim of their peripheral field. Okay. Sometimes people see mice or rat in the room or bugs in the room. If it is getting worse, it could be hallucinations, which is in there too. If you are seeing human figures or grandkids or kids or that sort of stuff, yes, that is proper hallucination. We have to review that medication. This is usually seen with a higher dose of levodopa, usually in the 800 plus or 800 or more per day, milligrams per day. Okay. Impulsivity and compulsions, if you are tailgating your car in the front or just getting ready to just dash off at the sign turning green, that sort of stuff, that is the early sign of an impulsive driving, right? So that kind of impulsivity or compulsions or blurting out things that shouldn't be said in public, that sort of stuff, you usually hear it from the spouses. So when that happens, we'll just say, maybe you're on too much of levodopa, right? Again, ropinirole and Mirapex, all that stuff usually can also cause hallucinations and impulsivity. So it's not just levodopa. It is a property of dopamine itself. We have something called dopamine dysregulation syndrome or dopa dysregulation syndrome. Sometimes what happens is patients start feeling good with levodopa, they overdose themselves. They'll just take it every hour. And that is not a bad thing if you are having off symptoms that frequently. If you're having off symptoms so frequently that every hour you need to supplement your levodopa, yes, you need to see your doctor and adjust your medications. But you can also see sometimes this, I feel good with levodopa, so I take a lot more levodopa. That is usually that dysregulation syndrome. All right, so here's the tips and tricks about how to take levodopa. So this picture here, taken from the National Institute of Cancer Research website. This is the stomach here, okay? And it's kind of located roughly around the left half, like that, baby. It sits under the heart. So your diaphragm is roughly around here. That is a shadow of the liver. So you can see the stomach ends up into the small intestine. The first part of that is called the duodenum, okay? And then you have this little, teal green part called this part called the jejunum, and then you have the ileum. So the three big parts of the small intestine, right? So most of levodopa gets absorbed at the end of the duodenum and the jejunum. So you have receptors there that actually take up what we call the long chain or neutral amino acids. So levodopa becomes dopamine and gets absorbed into the body, right? That's the story that we know. There are carriers, protein carriers that they look pretty much like this. So they attach, dopamine gets in there and it carries it to the body. So these carriers are in the body, in the stomach and in the brain as well. So you need them to carry this up there. Because dopamine, the amine, is part of a protein. When you take a lot of protein with your food, that can interfere with levodopa. This is a very common and very well known. Since the 70s, we have known that food interferes with dopamine absorption or levodopa absorption. So carbidopa itself can prevent levodopa from destroying it or getting destroyed in the body. Without carbidopa, if you take levodopa stays in your brain, in your blood for about 50 to 60 minutes and goes away. You basically pee it out. If you give carbidopa, it stays for about 1.5 hours or so. Now, if you take levodopa with a lot of proteins, it slows its absorption. It's not going to destroy the levodopa, so don't beat yourself up if you took a egg white or something with the medication, or took the medicine after eating egg white or something. But remember that protein in that egg white can slow down the absorption, so dopamine effects in your body might take a while to start feeding, or you start feeding it, right? Now, one other thing, and we'll talk about that protein interaction in a minute in the next slide, but I want to impress one other point here. There is a formulation called carbidopa-levodopa 10/100 milligrams. So a lot of doctors mistake this for, we're starting you on a small dose. Really, no. This thing, I don't know why it exists. We should probably write to our congressman and take it out of the market. This thing, it's a huge misconception that carbidopa 10 milligram, levodopa 100 milligram combination is a low dose, as opposed to carbidopa 25 milligram and levodopa 100 milligram. It is not a low dose. The levodopa in both of these are the same. They're 100 milligram. It's not a low dose. So if you have nausea, going to the 10/100 formulation doesn't help. It actually makes it worse. You need at least 1/4 of carbidopa as opposed to levodopa in the pill. So the best medicine of levodopa carbidopa combo should have 25 of carbidopa and 100 of levodopa. If you are taking one of those 10/100 milligram tablets, you might want to ask your primary care doctor or whoever is prescribing it to read upon that and then change that. Because generally, if you ask experts, they will actually change, they will tell you that 25/100 is the way to go. You need, if you're taking one tablet 4 times a day of carbidopa, levodopa 25/100, you have close to 100 milligrams of carbidopa in your system. That actually prevents that nausea much better than the smaller dose of 10/100. Okay, that is why the carbidopa should be at least 25 milligram in single pills. Okay, and that is, we've shown that the low amount of carbidopa is not good for the levodopa, because you need to have the levodopa in your system for longer periods of time for it to work. And more carbidopa means it helps the levodopa stay alive in your body. So you need that roommate, but at a dose of 25, not 10. Okay. All right. The food problem, right? So when I recommend carbidopa, levodopa, the way I recommend it is, I would recommend taking it 30 minutes before meals. I usually recommend it no less than 4 times a day. Some patients, if they are very mild in their symptoms or they are very early in their disease, I might say 3 times a day is fine, because it doesn't look like your disease is that worse, or you have a lot of symptoms in the evenings. So you can spread it out by about 6 hours apart, right? Ideally, if you look at the way levodopa carbidopa works, remember the half-life, the concept of half-life is important there. Half-life means the amount of time a drug takes to become half of what was given before, right? Levodopa becomes, or if I give you 100 milligrams of levodopa, it becomes almost 50 milligrams in your body, assuming that all 100 is taken into the brain within about 2 hours. So by 4 hours, you're almost going to have no levodopa in your system at all, right? So I would recommend, generally, for a patient with a lot of rigidity, bradykinesia, stiffness, and all that stuff, I would recommend taking it 4 times a day, about 4 to 5 hours apart, so that when your blood levels goes up and starts coming down by that 4th hour or so, I want the next dose to start working. Remember, it takes a little bit of time in your belly to get it absorbed into the brain. So you need to take it soon enough so that it starts working in the brain, right? So the way I usually spread it out is 8 a.m., 12 noon, 4 p.m., and 8 p.m. Most of the patients in the early stages, the first 5 to 6 years or so, have some dopamine replenished at night when you're sleeping. Sleep requires this kind of or your brain requires a sleep to replenish the levodopa or dopamine back naturally. So most patients don't need a little bit of dosing at night. In advanced patients, obviously, you need an extra dose in the middle of the night, maybe. But yeah. So I would recommend taking it 30 minutes before meal so that your belly is empty and this can actually get into your brain and then start working. Now, remember, like I said before, these amino acids in protein-heavy meals can actually cause slowing of absorption of levodopa. In fact, there was a funny study done by this company that actually came out with inhaled levodopa. You might have probably seen some of them out there, the company actually. So when they did it, so they gave 17 patients a very heavy, protein-heavy and fat-heavy meal, okay? And the meal is in there. 2 fried eggs, 2 strips of bacon, hash brown potatoes, 2 slices of buttered toast, and 1 cup of whole milk. American diet, right? Or a quarter pounder hamburger with cheese, small fries, and 1 cup of whole milk. So yeah, it should come with a warning and probably an insulin pump and probably a statin, whatnot. Anyways, yeah, I don't know. They got 17 patients to do this. So up top here, you gave this patient this heavy meal and had them inhale levodopa. So they bypassed the GI tract and got it inhaled and got it absorbed through the lung. It was peaking up pretty much as we expect. Within 15 to 20 minutes, everyone's blood level was going up. And so here it's the level of levodopa in the blood. Here is the time, by the way, the y-axis and x-axis, sorry. So on here you can see the minutes. So within 15 to 20 minutes, the early peak is starting. And as you go, some patients, again, this is 17 patients all plotted in one big graph. So pardon if you feel like it's all straw and grass there, but all these lines represent one patient, okay? One line represents one patient each. So when you, on an average, around 45 to 60 minutes is when most patients actually peak, right? This is bypassing the GI tract. The same group of patients, or actually recruited in 2 halves, like 17 patients of the same stage of Parkinson's disease, given this massive diet of all this stuff, you can see it was all over the place. So levodopa was not properly being absorbed in the GI tract. These were patients who were given levodopa by oral means. So you take a pill and measure their blood. Their levels were all over the place and they peaked somewhere in this range. I'm just putting a big shadow in there because it's all over the place, but you can see it takes almost 3 hours, up to 3 hours to actually peak, right? So you can see this was an extreme example to show that high fat and high protein diet can slow down levodopa. And there have been plenty of studies that have shown that pills don't properly break down in your belly, get into the brain. So it's very difficult for patients who already are losing a lot of weight to not eat a lot of protein or fat. Their family and their primary care doctors are telling them, yeah, you're losing a lot of weight. You need to eat more, right? And then I'm telling them, no, don't, So yeah, what we have found in general is that we can't tell Parkinson patients to not eat protein meals because of the shaking and because of the stiffness and all that stuff, you're burning a lot more calories than other people. So you lose a lot of weight generally with Parkinson's disease. That is well known. So what we recommend is, okay, throughout the day, eat more carbs if you have to eat meals. Carbs don't interact with this protein that much. So probably, a minestrone soup or whatnot. Eat that protein-heavy meal later in the day when you're not taking your medication. So that is usually what is recommended. Again, there are some studies that have come out and said, this is not applicable to every patient, which I agree. Okay, it's not applicable to everyone. You need to find your own rhythm. But in general, we have to tell patients, we are telling patients this during the day when you're taking the medications, try to take your medicines about 30 minutes before the meals or 60 minutes after the meals, because that is when your bowels have kind of moved the food down into the rest of the GI tract, lower into the small intestine. So you have some space in that upper part of the GI tract to absorb levodopa. So the medicine is not competing with your food. Okay. And this is a problem with all chemicals that compete with natural foods. Ibuprofen doesn't have it, aspirin doesn't have it, your beta blockers don't probably have it, but these chemicals, dopamine-like chemicals, have this problem, unfortunately. All right, so the nausea problem, I have to touch upon that. It's a big problem for most of my patients. Carbidopa itself is available as a separate pill. It's very expensive. I think it's around $160 or so per month on average, but there are coupons that you can get to bring it down to about 45 or so. I think I haven't seen anything go below 40. Again, that is a hard, that's a big, expense for somebody who's on Medicare, right? So it is an expensive pill. So talk to your, politicians to actually bring the cost down. I don't know. Domperidone has been used where I practice in Asia as well as in UK. Domperidone is another medication, which is an anti-nausea medicine. It doesn't get into the brain, so it can actually prevent this nausea in the GI tract itself. And it's a fairly safe medication. The problem is it is not available here. It's available in Canada, but US has not approved it. Mostly because there have been some reports of cardiac toxicity where your heart rate actually can be affected by this medicine. So FDA said no. And now FDA has opened up this for Parkinson patients and patients who absolutely need domperidone. Again, the problem is you cannot get it without a special, request that goes. We have to fill like 3 pages or something and fax it every month or so to FDA to get that as well. So it's a little bit of a tricky thing to really. It is illegal to, ship it from Canada here. So we have to do that paperwork to get that. So if you have severe nausea, yes, I'll do the paperwork and get that for you. But the problem is we can actually, this is used everywhere in the world. It's not like a dangerous medicine that other people are worried about. It is used in Europe. It is used in Asia. So why don't we have it? Yeah, again, talk to your congressman. All right, last slide. I think we're good with, okay. All right, so these are the different versions of levodopa over the years that have come out, right? Controlled release and extended release levodopa are available. On the right-hand side, I have some challenges that I've mentioned there. Again, this should not deter your doctors from prescribing these. These are applicable to individual patients, but just understand that the extended release or controlled release levodopa, the main challenge is less medicine, less levodopa from this form gets into the brain than the classic levodopa, carbidopa, 100 milligram tablets. So I still prefer the old levodopa, carbidopa 100 because it acts as quickly, as predictably as possible, and also very cleanly, as opposed to all of these, extended release formulations. But over time, that smoothness of the blood levels of levodopa go away because your brain doesn't hold on to levodopa. Remember, I told you, right? Your fridge doesn't have enough space, or you don't have enough Tupperware, or whatnot, Ziploc, so you cannot store this thing. You have to throw out the food. Your body starts not storing or begins to not be able to store the levodopa in the brain. It basically starts using up the levodopa right away. So you get a lot of these wiggly movements and it starts going away, right? So that is where we want medicines to make the levodopa last longer. That's point number 2. Catechol-O-methyl transferase inhibitor, or COMTs, they can actually stay in your body and help levodopa, or stay in your brain and help levodopa stay without being destroyed quickly. So a medicine called Stalevo, you might be familiar with. It has a chemical called entacapone. That is what the COMT is. Entacapone can make the levodopa stay longer in your body. There is another chemical that's come out in the last 3 or 4 years. It's called opicapone. Then there's one in Europe called tolcapone. All of these can be helpful. They have some weird liver side effects. That's one reason why not all of them are used willingly, but we still use them. When you use these extenders, levodopa causes that accelerated effect a lot. So a lot of patients will have hallucinations as side effect. A lot of patients will have a lot more dyskinesias because of that extra movements you have, right? So that is a challenge or a side effect. Again, there are patients that need this. So I'm not saying because of the side effect, you shouldn't use it. I'm just updating you on the side effects. Now, you've heard of Ritari, which is actually a capsule where you have levodopa in little sprinkles. Now, this chemical is a clever design of multiple layers of levodopa. Each of those sprinkles in the capsule have 3 layers of levodopa. So when the first one dissolves in the belly, it starts working, while the other sprinkles start dissolving gradually. So it is designed to give you a longer 6-hour stimulation by each of the layers slowly dissolving into the brain. Now, if you have GI problems and if you have a lot of protein in your belly, or if your GI doesn't actually work properly and you have a lot of bowel movement problems, these medicines might not work because they all need your GI tract to really work well. So if you're taking by mouth these medications, then you need a clean GI tract to really work. And that is a problem for a lot of Parkinson's disease patients. And that's when we introduce DBS as an option. We introduce jejunal infusion, which is Kyowa, AbbVie's, product is, I think, out there. AbbVie and another company, Mitsubishi, have come out with a skin injection for levodopa. You've probably heard of that Produodopa, which is being marketed just now. These are actually injections where you have a pump of levodopa that kind of gives you a little bit of levodopa throughout the day and throughout night, maybe if you want to, so that you have a steady level of levodopa continuously in your brain instead of you remembering to take it, go through the belly, and then get absorbed. You have the inhaled version of levodopa. You can't inhale it all the time. So we use it as a rescue medication. If you are frozen and you don't have that on effect and you need it quickly, remember that little experiment, right? They actually gave inhaled version of levodopa. It absorbs in the lung instead of the belly. So you can use that as well. A skin patch is being designed, but we don't know when it's going to come. Levodopa implants, maybe. We've tried fetal cell transplantation, stem cell transplantation. It's not worked very well, but we're still going to try it again still. Okay. So that's it. So levodopa is currently, in my mind, it's the platinum standard, not gold standard in Parkinson's disease. I follow the American Academy of Neurology guidelines and Movement Disorder Society guidelines. You start, that's my first medication to start, unless there is clear indication that something else should be started. So I started early. I usually scale it up to at least, 800 milligrams a day, 400 milligrams for sure a day, which means 1 tablet 4 times a day, or maybe even 1.5 or 2 tablets 4 times a day. I usually stop using anything more than 1,000 milligrams a day if I don't see the benefits of it. Okay, and I just want that quality of life up front. Give the patient the quality of life, the ability to work out, ability to exercise, ability to do what they want to do early on instead of waiting for another 5 years when they really don't, cannot move and they're in a wheelchair. I don't want that. So that's why levodopa is so important. Unfortunately, for 100 years, we have had this drug or this chemical. We haven't found anything better than that. So hopefully, with all your, input and research and everything, we'll have something better coming. That's it.
You guys hear me? Oh, there. So thank you so much, Dr. Najal, for that great presentation. Just a reminder, everyone needs to stand up, walk, keep moving. We know that we have a long day ahead, but I want to make sure that you guys are still staying active and moving. So please feel free to walk around, walk in the hallway, whatever makes you feel the most comfortable. We have some time for some brief questions. Dr. Najal will still be here throughout the day. So if you guys have any questions, you can feel free to ask him then. But if anyone has a pressing question, you can go ahead and ask that now.
This is just a really quick one. Does the type of protein make a difference, like eating chicken versus eating meat versus eating fish?
Good question. For levodopa, it doesn't. So far as we know, levodopa, the dopamine itself actually gets slowed down by anything that has other proteins that are in the same category. They don't fight with each other. The reason is because the intestines have a carrier molecule. Remember, I told you about the carrier, right? Those actually prefer the natural ones in the food. And if you have chicken protein or beef protein or milk protein or yogurt or any kind of egg white, they all have the same proteins that work, fight or compete with levodopa. So the protein doesn't matter.
Any other questions? I think that's all.
Even if you have to take levodopa every 2 hours, 21 pills a day. It's a train wreck.
Yep, absolutely. I totally understand the reason. And this is because there are some patients, it doesn't necessarily mean that your disease is getting worse and worse and worse. It is just that the cells that I showed you early on at the top, right, of the presentation, those cells have slowed down so much that they don't seem to be able to have that little Ziplocs and Tupperwares to store your levodopa enough. So it burns through, right? A lot of patients burn through this medication very quickly. In my world, I usually will assess their patients' general health. Deep brain stimulation will be an excellent option for a patient like that. Okay. Yeah. I know everyone is scared of it. That's my next talk. Come to the next symposium. Yeah, I'm going to convince you that deep brain stimulation is really good. Okay. Hopefully I've convinced about levodopa. So yes, that is the kind of patient that I would prefer levodopa to, I would prefer them to actually get less on levodopa. So I would want them to have the same effect of levodopa, but without levodopa. How do you do it? Deep brain stimulation does the same thing in the brain without the medication. So that is one option. The other option is they can go for duopa or the pump infusion as well. But again, pump is giving you dopamine in a different way, right? It's giving you, dopamine in the GI tract or under the skin. So you're still getting dopamine itself, not another one. So that will be an option for you. So talk to your doctor or come to their site.
What do you think of taking 5,200 at night?
Can you repeat that again?
What do
5,200?
you think of taking the 5,200? At night?
Right. So again, the 5,200 milligram tablets are higher levels of carbidopa, levodopa. So they are 50 of carbidopa and 200 of levodopa. So I sometimes prescribe it because a lot of patients after they have crossed to a certain stage of Parkinson's disease, they seem to have less production of natural dopamine in their brain. So those patients might need an extra bolus of levodopa before they go to bed, so they don't wake up in the middle of the night. The problem with those formulations is that they don't seem to have a good bioavailability. We have seen that only about 70% of that levodopa gets into the brain, as opposed to the regular levodopa, 80 to 90% gets into the brain. So not enough levodopa from that formulation seems to be getting to the brain. So even if we use that, it seems to stay longer in the brain throughout the night, but not very effective for keeping, or if we want to use it during the day, it doesn't last as long enough. So that's totally appreciable. That is actually appropriate for that. That drug is appropriate for that patient. But again, I wouldn't use it throughout the day as a substitute for the regular levodopa. Yes, sir.
Is the same mechanism for freezing, the one that you showed us on your first slide. And part two of that would be, freezing seems to occur often at entrances. What is the mechanism for that? Could it be the black hole you mentioned? In a visual way.
Right. So the freezing mechanism has 2 or 3 other parts to it. Okay. This is not exactly the reason for freezing. Freezing happens because of the gate centers in the brainstem being affected. We think that is the case, but they are also controlled by the frontal lobe as well. So there are other mechanisms which involve acetylcholine, another protein, not just dopamine. So it happens more often to patients in the advanced stage of Parkinson's disease, but there are a few patients who have that very early as well. That doesn't seem to respond to dopamine at all. And most of the time, it doesn't respond to any medication whatsoever. So we don't have a mechanism by which we can actually give you a medicine and take it away. We have looked into stimulating the brainstem to see if that actually helps you overcome the freezing. That research has not gone anywhere promising. We know that patients, when they get to a threshold or when they actually initiate their walking, they start shuffling and then freeze. And then they have to imagine a line in front of them or remember to walk to a tune to kind of march, then they can overcome it. There is even a cane that has a laser line that creates a barrier in front of them. So they can think, oh yeah, I have to step over that, right? So we have to work with physical therapy and the rehab clinicians to learn that process by which you can imagine a line in front of you and step over it. That's how freezing is often naturally treated. It's not a treatment. It is just you being trained to overcome the freezing. That often happens because remember the brake system is a little too applied in the brain, and then you need the natural when you get up, naturally, your brain, the basal ganglia has the capacity to, yeah, you got up, next thing is you walk. So it's a more automatic process. In patients with freezing, we think that the automatic process affected. Again, if I have to go through the neurochemical system, we'll be here all day, sorry. The spots in the brain, we think it is because of the visual cortex being affected. In the back of the brain, there is a part of the brain called the occipital lobe. This controls vision, and this seems to be stimulated by a dopaminergic system. And this is also the area where we think hallucinations happen. So these spots are called illusions. They are kind of, somewhere between a hallucination and a visual phenomenon. So again, the chemistry of that is a little too much for this crowd at this point. We'll have another talk probably planned for that.
All right, let's start with a round of applause.
Thank you.
We're going to transition to Dr. Legman from VCU. So, Dr. Legman is a mid-career clinician scientist and board-certified clinical neuropsychologist who engages in clinical practice and research initiatives at VCU's Parkinson's and Movement Disorder Center. She has an excellent clinical and research training in neuropsychology and conducts research and treatment of mild cognitive impairment, emotional disorders, and neurodegenerative illnesses, including Parkinson's disease and other disorders. She focuses her research on developing neurocognitive behavioral interventions to improve cognition, emotional functioning, and quality of life in individuals with neurodegenerative disorders and their care partners. Recent publications have focused on the needs of individuals with Parkinson's disease and their care partners and outcomes from multiple clinical trials investigating the effectiveness of psychosocial and pharmacological interventions in individuals with Parkinson's disease, as well as neurodegenerative illnesses. Please welcome Dr. Legman.
Good morning. I hope this is this, if I hold it close, is it loud enough back there? Yeah, okay, good. Well, it's great to be here. You weathered the rain, and I'm so glad you all got here safely. I gave out handouts. I'd like you to have things, I want you to think about some of the things I talk about, hopefully after the talk. So hopefully you have a handout. If you don't, there's a lot of couples, you might be able to steal one. And I also, at the end of it, have my email, and I'm happy to send it to anybody that would like it, okay? So I'm going to talk about resilience in Parkinson's disease. And, resilience, when we think about it, what comes to mind? Thoughts about being more strong, getting through something, and facing adversity and making something positive of it, right? I have to think, I gave a lot of talks during COVID, and do you remember how we talked about 2020 being the worst year ever? And then 2021 wasn't much better, and then 2022 wasn't much better, and 2024, I don't know, mine has been pretty rough the first month or two, so I don't know, how are you all doing? Do you feel like it's getting a bit better? Hopefully, I'm agreeing with you that it's sort of half and half, I'm not sure, but maybe we're getting better at coping with it, right? So I hope so. We've had a lot that we've gone through. When people get a Parkinson's diagnosis, as you all know, it usually comes kind of out of nowhere, and it's not what you were expecting. Most cases are what we call sporadic, meaning you don't have a family history, and it happens. And as Dr. Rajan was explaining, you've lost a lot of dopamine before you even come into the doctor. Your body has been changing, but it's not at a level that we detect. Naomi is going to work on trying to get the background music, but you get to hear me talk while there's tinkling in the background. And if you hear the music, you're not hallucinating. I always tell people sometimes it's a shock. Sometimes you've had symptoms for a few years and you're relieved to finally have an answer that you don't have I've seen people have rotator cuff surgery, been told they have other issues, and it turns out they had Parkinson's, stiffness, or tremor. So you can come about it as a quick diagnosis or several years of struggling to get that diagnosis. But at some point, you have to grapple with that you have that diagnosis. And I want to talk to you about kind of strategies that can help you improve your coping and resilience. So it really is a whole body disease. You know, we heard about how we focused on the tremor or the slowing or the rigidity, and that was the focus early on in Parkinson's. And now we really recognize that there's non-motor symptoms, and it has to do with how it affects your whole body. Like we learned about how it can lower your blood pressure, it can slow absorption in your GI tract. You can get orthostatic hypotension and other autonomic changes with your sweating. You can get sleep disorders. So it affects a lot of different parts of your body. Have people heard about the non-motor symptoms before?
Yeah.
Yeah, good. I focus in on, of course, cognitive and mood changes. So that's what we're going to talk about more in my talk. But non-motor symptoms are among everybody, but if you go to a support group and talk to people, people might have different things. Some people never have sleep problems. Some people have terrible orthostatic hypotension. So there's a lot of variability in the symptoms, but non-motor and motor symptoms tend to fluctuate together, and the non-motor symptoms are fairly debilitating. And we're a little behind the curve on trying to treat them. So you have carbidopa, levodopa for the movement, but we have all these other issues we have to deal with. And you probably spend a long time talking about those in your doctor appointments. So we've got to work on that. I'm going to share with you more coping strategies, but as far as mood symptoms and their frequency in Parkinson's, we see depression in 35 to 40% of populations. I will tell you, if you have a history of depression, you're a little more likely to experience it with the diagnosis of Parkinson's. We also see high rates of anxiety. We're going to talk about that. I'm sure you're going to have lots of things to say about anxiety. And apathy is a specific term that we use. It goes with that, like we were talking about freezing of gait. When you initiate an activity, you get stuck. But apathy is the emotional part of you just have no interest or get up and go to do something mentally. You know, you just struggle to make yourself do it. When you actually do it, you enjoy it, but it's starting it. It's hard on an emotional level. People often ask me, the doctors send patients to me and say, is this person depressed? There's lots of symptoms of depression. You know, we can think classically of people being more tearful or not having interest or pleasure in things. But we can see a lot of physical symptoms where you just don't eat, you don't sleep well, you might feel keyed up, you might just not be able to pay attention to things, you could be really irritable. So that can be something that can come up. Anxiety is a little different. So for anxiety, a lot of people tell me they feel kind of nervous or on edge. We heard about some of the physical reasons you might have that physiological feeling from the medications, but you also can have running thoughts. You can kind of get stuck on things. You can just worry about what's coming next. You can have difficulty focusing as well, but you also can have lots of physical symptoms. And when you're looking through these, you probably notice that there's a lot of overlap. And so that's why sometimes a neuropsychologist or a psychologist can be helpful to tease out, is this part of Parkinson's, or is this a major depressive disorder that's been there and now is worse? Or is this a reaction to medicine or adjustment or different things like that? I'm alluding to this, but we talked a little bit about physiological changes, the loss of dopamine, but we also have the reaction to the illness, and that it changes what you probably had thought your life would be like. We all have kind of a plan that we think, even if we haven't articulated that well, And I meet a lot of people that the diagnosis comes when they're considering, they're at the top of their career and they're considering retiring, or they have just retired not so long ago. How many people does that fall into place for, either of those situations? Yeah, so a fair number of people that hits at a time, you know, that causes a lot of turmoil for you to readjust to. The emotional changes we can experience also can impact our quality of life, our care partners' stress level, but our mood symptoms, interestingly, if untreated, can make our Parkinson's symptoms and functional abilities worse too. So it's kind of like a vicious circle. So some people, if you have the idea like, well, I just won't treat my mood, I'm just gonna treat the motor symptoms, you actually can make your motor symptoms worse because you're not managing your mood. So they're all very interconnected. And when we think of resilience, like how do we make be more resilient and get through things? I love the idea of that slinky, you know, you kind of bounce down and then you bounce back up, right? So hopefully we do. Resilience involves recovery, sustainability, but also growth. It's not just staying the same or getting back to where we were, but it's hopefully even doing better, right? And so I want to talk about that. A lot of times with people in clinic, I hear over and over what they've let go of or what they've stopped doing, but I don't hear what they're trying more or new. And that's important to focus on. So when we think about resilience, and particularly that Parkinson's usually affects people in their 60s and 70s, I have seen juvenile cases and much younger cases, but that's not the norm. What do we think about with resilience and aging? Do you, just in general, what kind of words come to mind when you think about how you've aged, how you've become more resilient with age? You can just throw out terms. What do you want to say?
Smarter.
Smarter. So you definitely have more knowledge, right? We're way smarter than we were when we were 20. I am going to tell you as a neuropsychologist, our frontal lobes don't fully form until 25. So my opinion is you shouldn't drive or have children before that. Sorry. Okay. What else? We're smarter.
Mentally tougher.
Yeah, we have a little more fortitude. We've been through some things. We know not to get down when you get the bad letter or something isn't quite what we want. Yeah. Ken, sorry. Wisdom, resourceful, yeah, so I have some of these on here. So in our culture, we kind of view aging, there's a lot of ageism stuff right now about we're just, oh dear, you know, less, or we're getting old and we're supposed to look like we're 20. But as our physical health can have more challenges, we can have a lot more skills. So resourceful, wise, someone said, flexible. Sometimes we can be inflexible, but we also have learned to roll with the punches, that's for sure. Some people are more patient. I have to say, as I near 50, I'm more like, I'm not dealing with that. So I don't know, patient or maybe definitive, I don't know, we'll see. So lots of things, you know, and so we have those skills to call on, and we can call on them with Parkinson's or any other issues we've had to deal with. And I had a research student very interested in resilience and sort of how to study it. And she wanted to know how non-motor symptoms and resilience impact mental health and quality of life. We did a cross-sectional survey. Probably some of you did it because I went around the state and gave people questionnaires and they all mailed them back to me. And somebody may have done that, but we had 138 community adults do it, average age of around 65. And we found that after controlling for demographic variables and how many non-motor symptoms you had, that resilience was associated with all of the mental health things. So if you're more resilient, you have less depression, you have less anxiety, you're just coping better in general. And non-motor symptoms were associated with more depression and worse quality of life. So we have an illness that is just prone to making our quality of life and mood worse. And we have to do things, just like that slinky, we have to do things to overcome that, you know what I mean? So I think about how do we grow resilience? The research, there's some debate, there's some questionnaires. Psychologists make great long questionnaires. They're really terrible sometimes, but there is a debate about what part of it is a trait. You know, you're just born with your demeanor versus what can we do to grow it? I'm kind of more on the idea that we live through our experiences, and as we get through them, they change us. Do you know what I mean? So my mom has moved in with me, and a month after moving in, she broke her ankle, and I'm coping with that and helping her. And I think if that had happened when I was 20, I would have been a different person to handle that. You know what I mean? So all my experiences, you know, whether it's getting through some tough things in my career or whatever, help me kind of have perspective on what I need to work on with her. So there is some research talking about 7 C's of resilience. This is from a human development perspective. And so some of them are like, we're talking about character or our personality, but coping is a big one that helps resilience, how we cope, our connection with others, and contribution, what we're doing, and competence. And I would say competence, think about coming here. You have to learn about your disease. You have to know how, Dr. Rajan used the word rhythm. You have to know how the medicines work for you. You have to understand some of it to tell your doctor what they need to know to work with you. And so that's part of your competence. When we say control, I just put a caveat in here. I talked a lot during the pandemic about really being clear what you can control and what you can't. Do you remember when the people had fights about toilet paper? And there were other things that really we shouldn't have online because it's bad things to remember. But think about what you can control and what you can't. You know what I mean? You can't control what's going on in the world or some things that may seem very chaotic, but you can control limiting your social media, turning off the news, finding fun things to do at home, connecting with others, whatever that needs to be. This is from the pandemic, so it's kind of funny when I read about the toilet paper. Who would have thought? I still have about 6 cans of Lysol. I'm not sure when I'm gonna use them all, but it's probably for my life, right? The important thing to know though is depression is treatable. So it is pretty complicated, and that's not my area either. But dopamine and serotonin, we talked about the different neurotransmitters. Sometimes, like the carbidopa-levodopa helps your mood or you appear a bit brighter. But sometimes you need another one. I explain to people, when you actually talk about dopamine, I know there's at least 5 receptors in the brain. So we call them DA1, DA2, DA3. So it's not like one medicine just hits everything. So sometimes you have to have another medicine on board. And remember, about 40% of people with Parkinson's have some depression. And if we don't treat the depression, the Parkinson's motor symptoms get worse. So you might need another medicine. A lot of people tell me I don't want another medicine, but I'm like, well, we can't pack it all together. I'm sorry. Just think of it as a package deal though, okay? So medicine can help and therapy can help. Some people will do one or the other, but not both. But the research really shows that both in combination helps the best. And this is because there's chemical things we could need medicine to help us with, but sometimes we need to help ourselves with changing or adapting to situations. And that can be helpful to have someone help you figure out how to do that, but also be a little accountable. You know how you mean to exercise and weeks go by and you haven't gone? I actually have my gym clothes hanging on my door. I mean, they're right there. So I know all about this, okay? So accountability is a big thing. I encourage people not to be kind of hesitant to reach out to connect with a psychologist or a mental health professional. It is hard to find them, so that can be a struggle, but there's a lot more avenues now with online therapy or different ways of getting that. Anxiety is also treatable. A lot of people tell me, so part of that wearing off phenomenon of the medicine, that they start to feel more anxious. And I don't have Parkinson's, but I can imagine as you feel these movement problems coming on, that then you have the tremor, but then you also have your mental state of I can't manage this, I can't do what I want to do, and more anxiety brewing too. And then what happens when you're stressed with Parkinson's? What happens to your tremor and your movement? It gets worse. So you just have this vicious cycle, you know, you're anxious about it and then it happens and then it keeps happening. I do encourage people to really make sure they use strategies for anxiety from what I call behavioral or perspectives of what you can do yourself at home. And we're going to talk about some of them. Because when you take a drug for anxiety, as soon as it wears off, you feel it. And then you want another pill, right? I mean, so I want you to feel like you have things to do to help you all the time. Sometimes you do need a low dose like medicine all the time because the anxiety is that high, and that's fine. But if you're not doing the behavioral things, I always tell people you're kind of leaving on the table things with no negative side effects or costs, and you're not helping yourself. So that's important. I'm going to try to make up a little time, so I'm going to go through these kind of quickly, but you have handouts. But how do we make our coping and mood better? We do need relationships with friends and family. And a lot of times with that retirement, your social network really goes down if you haven't made a big social network outside of work. So that can be something to really work on as you retire or stop working. Counseling can help. It can be through a medical perspective or pastoral counseling. Support groups can have an element of that where you just have camaraderie, that you're all going through similar things, even though I will tell people no two Parkinson's symptoms are the same for two people. You know, they really vary. I also encourage people to learn more mindfulness strategies. I'm going to talk about a study involving those in a minute. I put Yoda on here just because you don't have to be sitting perfect. I can't sit like that. And none of us can get up from the floor, right? So anyway, so that isn't going to happen. But don't feel like you have to have that perfect level to do it. You can do it at whatever rate you want to. You really do need to look at your physical wellness plan. So how are you sleeping? How many people have sleeping problems? This is a huge issue. And I have a lot of strategies I give people behaviorally to help on that, but sometimes medicines are helpful too. Your diet is very important just to remain healthy. I will tell you from a neuropsych perspective, the research really shows that if we engage in cardio intensive interval training, that's a fancy word for getting on a stationary bike and pressing the hills and valleys, that helps blood flow to our brain and actually improves our memory. So instead of saying, my memory's just here or going down with age, we can actually make it up. Remember the Slinky? We can make it better, but we have to go do it. And that's hard. We're going to talk about that. But if you can do, the recommendations are a really high number every week, but I tell patients, just aim for 3 times a week, 30 minutes on a bike. You know, you just set the thing and either watch a TV show or you put on music. The key though is when you're doing this, when you're pushing hard, because it's really the change between pushing hard and recovering, you shouldn't be able to talk normally. If you don't sweat, you know, those people at the gym that they just kind of stand around and I don't know what they ever get on, but I'm like, what are they doing? That's not exercise, okay? So you have to get on, and if someone came up to you, you'd have to be like, I don't know, I can't talk to you right now. Like, that's it, leave me alone. You know what I mean? That's exercise, okay? To whatever is cardio okay for you with your doctor, but you have to have some exertion and then recover, because that's how the blood flow changes to the brain. And that's what's really good for us. I did put a Q on here. Rocksteady Boxing is in Williamsburg. How many people have been to Rocksteady Boxing? I'm so excited to see all those hands. I always thought boxing, oh my God, we have people with Parkinson's boxing. That, if you're a professional boxer, your likelihood of getting Parkinson's goes up a lot. So Muhammad Ali experienced that. We don't want lots of head injury, but you don't hit each other, right? No. So that's a great class. You get some cardio activity. You also get a lot of mental flexibility, moving your feet right and left, which I can't do, and other things. So it's very helpful for mental flexibility and speed of processing. I'm glad to see you all know about that. If you don't, you can Google it. I didn't put websites in here, but so we alluded to exercise is key for Parkinson's. I would kind of, I don't know, you have to weigh in, Dr. Rajan, but I would say if exercise is almost as important as levodopa carbidopa.
Absolutely.
I mean, 50-50, I mean, I don't know, I mean, if you're not doing it, you're leaving another thing on the table. The thing is, it's so hard to make ourselves do it. For the people who've been exercisers, they're great, you know? Well, the runners have a hard problem because they really hate aging and not being able to run, but I've never understood why you would run, so. I just don't do that, I'm like, you're crazy. But you really need to exercise the way you go to a doctor's appointment or the way you brush your teeth, you know what I mean? Like, you don't skip. How you make yourself do that is, people find that if you schedule it, you're more likely to do it. If you pay to go to a class, you're more likely to do it. If you go to a class where you meet people and you feel a little social expectancy, like they'll know I'm not there, that makes you go. Sometimes it's your partner, the care partner says, put on your clothes and we're going, and you're like, and then when you're done, you're glad you went. That's that initiation and apathy. You have to have a buddy or someone who helps you get there. And you just have to do it. You will never feel like doing it, but you'll probably always be glad you did it, right? How many people find that when they exercise, they're always glad they did it? Yeah. And how many feel like exercising? Yeah, see, that's the problem. So anyway, seated Tai Chi, I have people who do that online. Even if you have more mobility issues, you can do seated Tai Chi, seated stretching. It's still really good for getting rid of some of that rigidity and tension. I love this picture because social connection, you know, we in America live very isolated lives. We don't connect, but we are creatures that should connect. And we experienced that in the pandemic when we all couldn't get together, even in our sort of minimal way that we do here. What happened to our moods? We went nuts. Yeah, I mean, most of us didn't cope well. I was on some like psychology meetings, and there were, I mean, those overachievers that were like, oh, I repainted my basement and installed whatever, and I'm looking at them and I'm thinking, yeah, I just kind of milled around the house like anxiety central, you know what I mean? I mean, it wasn't a good thing. So I tell people with connections, instead of losing things that we're doing, I want us to try new things. So I have like 3 minutes. Working on it. So classes, hobbies, the Osher Learning Center, have people been to the one at William and Mary? Nobody. That's an adult learning program. You can go to classes. I tell people, you want to learn something, your brain likes novelty, you want to learn something you don't know. You know, as we age, we get very comfortable in our career, we know what we know, we're good, we're flying high. You want to do things you've never heard of and try that, because that's when new synapses are getting made. So if you've never learned about Egyptology, this is the time to figure out about that. He's shaking his head no to something else, but I'm just making fun of him. We want to manage our stress. I have a hard time with this, but music is a great way to manage stress. I'm just going to point that out. Exercise. I just said our brain likes novelty. So card playing, travel, within the range that we can, but those are all things that we benefit from experiencing. If you've never painted, you should try painting. You never know. You could be good. How do you know? You know? I'm going to go through these things rather quickly. But we did do a mindfulness program to study that in patients and caregivers. And what we found, everybody learned more about mindfulness, but people with Parkinson's had improved mental flexibility, more attention, and they had fewer emotional symptoms and cognitive symptoms. So again, they could improve their cognition and their mood. So like that Slinky, they actually did better. So why wouldn't we sit and listen to relaxing music and try to calm ourselves down and live in the present? You know, it's a win-win. We also did an expressive writing intervention. I had a graduate student who wanted to look at this, and we looked at expressive writing, which was about a traumatic or upsetting event in your life versus neutral. This is a well-known technique in psychology. And we looked at cortisol and stress response. And so we studied people for 10 months, which was a very long follow-up. She should have made this her master's, but she didn't, but it was a great study. Anxiety declined in everybody, and learning and memory improved. I will tell you, they journaled 3 times over a 2-week period for 30 minutes. So this isn't intense, you know what I mean? This is fairly short. And patients had reductions in cortisol reactivity, which was great to see. So what I want to emphasize to you is there's a lot you can do, and it's what you do every day, 52 hours a week, 365 days a year, that impacts how you're living. You go and see your doctor, what, once every 6 months, if you're lucky, 9 months, a year? All those other hours, what you're doing to cope, your exercise, your mood, your connection with others, all that is what makes your quality of life better. And you can actually improve your cognition and mood. Not just the Slinky going down because Parkinson's isn't the best thing or that we didn't want, but you can actually bounce it back and be higher. So I'd ask you, why wouldn't you do that? You know what I mean? So why I printed out the handouts was I wanted you to have things to think about. Where do you want to grow something in your garden box? You think of your little world. What are you lacking? Are you lacking social connection? Is your mood sort of lackluster? And I tell people, is there room for improvement? Yeah, that's how I softly encourage men who don't want to talk about their mood. I'm like, let's just say there's room for improvement. Okay. Guide them in, right? You know, look at where something isn't that great that you could make more inroads in. I do have a whole nother talk that strategies on improving cognition. Like we said, some of these mood things improve your memory and attention, but there's even other strategies. And that slide on the games and the cards, I mean, that is novelty. Your brain likes that novelty. So hopefully the next time I come to Williamsburg, I want people throwing out all the ideas of what they're trying new, or the OSHA program or different programs, or volunteering somewhere, or connecting with others, however you want to, you know, that you're doing and remaining active. If you have any questions, feel free to email me. And our website, we're kind of revising it. We do that periodically, but we put resources online. I know Anne has a great list, Ann Dietrich, of Parkinson's exercise classes in the state. We put that on our website. So we have a lot of things that you can find either from group support leaders or our website. Thank you so much, and it's great to meet you all today.
Thank you so much, Dr. Legman, for that wonderful presentation. We're gonna go ahead and first one. Does anyone have any questions does anyone have any questions before we move to our next presenter?
I was wondering, for people with Parkinson's who are maybe experiencing some of the depressive symptoms and want to be medicated, is it SSRIs that they're given?
Oh, there, thank you.
And then my follow-up to that would be, if you're taking levodopa, is there any like negative interactions with taking both?
I don't see the mic. Wait.
Sorry. Okay. There's a lot of different medicines that can be helpful. So I mean, we see SNRIs, SSRIs, sometimes combinations, like a lot of people with Parkinson's have some other pain condition. Cymbalta is very often used to co-treat pain and depression, but I have to say in my experience, I don't prescribe, but Cymbalta often needs another antidepressant with it to kind of bump it up enough. So really, you know, your general neurologist probably will try the first layer of Prozac and Celexa, Dexter, and those things, but a psychiatrist that knows about movement disorders can be great even for a one-time consult, even if you don't keep going, just to get the right mix for you. It often changes over time too, because the dopamine cells are dying over time, so we keep adding more. So when people ask me that question about, I don't want to take another pill, I often say to them, if you had a cardiac problem or diabetes, would you just not take the pill? I mean, if you don't want to, you don't have to, but, and I'm a big proponent of palliative care in a different context, but we want to help ourselves with those things. The interaction with levodopa, I mean, I don't see a lot of negative interaction, but I, like a physician, I would ask, but he's saying no, so
It rarely ever happens to that.
rarely ever. So things are well tolerated, but your personal experience, like if you reacted well to an antidepressant in the past, that's often the first thing they try, but there's lots of options. The other thing I will say is I encourage everyone, I got my mom to do this as well, to go to a gerontologist or a geriatric specialist. So the other part of this equation is that as we age, we metabolize medicines differently. And so the antidepressants in an older population may be different than younger. And then we put Parkinson's on top of that. You know what I mean? So that's a lot of variables. It's great that you're double boarded in psychiatry. I'm excited to hear about that because that's a big deal if you don't know that. Because you need someone who understands both Parkinson's and the geriatric aspect, you know, so that's important too.
Any more questions?
How about when someone takes Adderall and carbidopa?
But like I said, I don't prescribe medicines, but I have seen people take, I mean, have longstanding attention deficits. And so your neurologist would work kind of how that works with you moving forward with Parkinson's. On a separate sort of related note, some people, I mean, I've had the unfortunate experience of people being diagnosed with ADHD at 70, and then 3 years later come to our clinic and it's Parkinson's. So let me just say, you don't develop ADD at 70, okay? I want to kill these people. The definition of attention deficit, you have to have symptoms around age 6, and you know, they go from there. You don't develop them even at 25 when you start to feel like you're not doing so well at your work. That's not ADHD, that's life. So also not going to get me saying ADHD. But if you really have ADHD, that's fine. There are occasionally, and you can probably speak to this, we see people that will try Provigil or certain attention enhancing medicines just to see if they give you a boost. We're not saying you have ADHD, but it can help your attention. So sometimes we do trials of things like that, but that's again with your neurologist with care. But you know, unfortunately, you can have a pre-existing condition. So I mean, it doesn't mean that doesn't happen. I see a lot of people who are bipolar and then develop Parkinson's. And so then we have to coordinate their more complex psychiatric meds with the Parkinson's, you know what I mean? So that's not unheard of either, so.
Any final questions? Will it be last two, and then we're gonna go ahead and get started with our next speaker.
Not really a question, but one. I was diagnosed 7 years ago, and of course, threw myself into boxing and walking and all the exercises, and being a 68-year-old male, feelings aren't something we talk about. But I found my Parkinson's seemed to be getting worse and worse, so I brought it up with my neurologist, who referred me to a psychiatrist. And I met the psychiatrist and she gave me one med, but then she referred me to a psychologist to deal with some of the other issues. And I would say, all in all, I'm doing better now than I have been since I was diagnosed and taking care of the other things.
Because he goes out and tries everything. You didn't raise your hand with Osher, but I know you've been to some learning class, haven't you? Oh, what? But anyway, he did my mindfulness class, so he's up for anything, and that's a wonderful thing to be, especially with Parkinson's. So yeah, I would try to demystify. You may need to see another doctor. I just tell people, once you see a psychiatrist, you don't always have to go back at such frequency. They just need to get things set right. And that can be good for a while. It may need to be changed every once in a while, but it's, don't be scared of that. So, yeah.
Have one more question and we'll go ahead and get to the next speaker.
To what degree is the phenomenon ageism being addressed?
Yeah, fabulous question. So a gentleman that worked with us, Brad, I'm gonna blank on his last name. They recently wrote a paper about using the term the honeymoon of Parkinson's. I mean, this is like saying, I don't know what, give me an acronym for like a honeymoon of war. And you're like, no. You know what I mean? It's not a honeymoon. What they're referring to is what Dr. Rajan said is, you do well and have minimal symptoms for a while, and the meds really treat it really well. So, you've got a good 5 to 10 years before you have to start tweaking everything. But the term honeymoon sounds it's just not right, right? Yeah, well, it's like, who would be happy that they have Parkinson's? I see people with ALS and a ton of other conditions, so there are things worse, but we don't want to use language that kind of minimizes that, you know what I mean? And for ageism, it's the same issue. We have this culturally, this is a huge cultural thing. So it is pervasive, but I will tell you, I think more, of course, I connect with a lot of geriatricians and geriatric doctors. There's a lot more conversation about talking against that and people kind of speaking out that that's not appropriate. Because all those things I said we have more knowledge, we have more fortitude, we've been through things, we're not reactive. We know how it is to have it hard and make it happen through hard work and whatnot. But I've experienced this with my mom occasionally, like one time, it's not all the time, but one time we were out at dinner and the waiter never looked at her. And I thought, she's gonna give you the tip. You might wanna, you know what I mean? But they were looking at me, and it's not like she's soft-spoken or anything. So with Parkinson's, maybe you're so soft, somebody else helps you order or whatever, but it's just not right, But there is now an article, so I think there's more discussion in the medical field about how we could be contributing to it and trying to change that, particularly with Parkinson's. But it's a challenge for our whole culture. And then there's an extra piece for women. You asked as a man, but then women have had the ageism thing that you read that like after a certain age, you're just invisible. So that's not a good thing either. At least, men get to be dignified when they're bald or white haired. People always say they like my white hair, and I say, I'm just not gonna do that. So I don't care, but there's a lot of pressure to do some of those things. So yes, good question though. But the honeymoon question, I read that paper and was very impressed. So yeah.
Just a reminder, if anyone needs to stand up, take a bathroom break or movement break, you're more than welcome to do so. We want you guys to be comfortable. We have one more presentation and then it'll be time for lunch. Okay. So wait 1 second. So we have one more presentation and then it'll be time for lunch. So it's not time for, but just you need to take a break or whatnot, or movement break, you're more than welcome to do so. I was gonna get started for the next presentation, but if you guys need a break, we can take like a break or so.
Just speak or normal.
Oh,
Under there for some.
okay, we'll take a 5-minute break and then we'll come right back. Yeah.
Yeah. So generally, you're going down because the way you say doesn't change the disease. So that's why it's like giving yourself that so you can take it whenever you we usually do obviously so you take it. So I know it is very maybe take it. Every time we prescribe medication, actually I think it's so that's a very common. So I usually recommend as well so you wake up on well, they get early in the morning. I used to tell them you are at 6 a.m. So if you are waking up early, the stream that you call it, yeah, it's very okay, so you're not really stay like my recommendation, right? So my recommendation, taking it to you can take it space the next one. I would recommend taking like this is the reason why someone starts growling once you are talking it's very and then it's not it will. That is a problem that we have seen. But again, if you need coding, like I have a lot of things So what I usually recommend is definitely make wait for a 30-minute period so that your medicine has enough time to get to your body, and then the best thing to do would be to move your way to the one time. The protein doesn't make the processor, it's just that. So we'll just some people feel like you have lines stuck on the head. No, there's no line. Thank you very much. It's the freest thing you can get. Very good. Yes.
Yeah.
Chairs. Back to their.
All right, hello everyone. We're gonna go ahead and get started. So if you guys can make your way to your seats, we'll go ahead and just start with the next speaker. We have one more presentation and then it'll be time for lunch. And our morning speakers will still be here after lunch to answer any questions that you have. Can I use this? Oh, yeah, okay. Hello, everyone. Can you guys start making your way back to our seats, please? We have one more session and then it'll be time for lunch.
Okay. Okay. We can make it. I work at UAB.
Lights, people know them.
Hello, everyone. Can you guys please take your seats, please? Hello, everyone. I hate to yell. We have one more presentation and then it'll be time for lunch. We have our wonderful keynote speaker all the way from Alabama to provide a wonderful presentation today. So I need everyone to please make their way back to the main ballroom and please sit down for our next speaker. I appreciate your flexibility and patience today. I am pleased to introduce our keynote speaker, Dr. Brianna D. Miranda. She is our 2023 recipient of the APDA National Research Award. Dr. D. Miranda is a neurotoxicologist and assistant professor at the Center of Neurodegeneration and Experimental Therapeutics and the Department of Neurology at the University of Alabama at Birmingham. Her research is focused on environmental risk factors associated with neurological disorders, including Parkinson's disease, dementia with Lewy body, and Alzheimer's disease and related dementias. Dr. D. Miranda received her PhD in toxicology from Colorado State University and trained as a postdoctoral fellow at the University of Pittsburgh with Dr. J. Timothy Green-Morer. Her interdisciplinary background in neuroscience and toxicology laid a foundation to assess mechanisms of neurotoxicity from exposure to environmental contaminants. She also has a background using gene therapy and pharmacologic approaches to prevent neurodegeneration and experimental models of toxicant exposure. Her current research is centered on mechanisms of neurodegeneration caused by the organic solvent and PD risk factor, TCE, using environmental relevant experimental models of exposure. Please welcome our keynote speaker, all the way from Alabama, Dr. Brianna DeMiranda.
Great. All right, I'm gonna use this microphone. Can everybody hear me?
Yeah.
Okay, thank you. So I'm going to change gears quite a bit from our first two really wonderful speakers, and I'm so glad that I'm following both of our first two talks, because I'll be blending a little bit of what was discussed in both, but I'm definitely changing gears. You have a couple of caveats here. I'm not a clinician. I'm a research scientist, and I'm going to be talking about environmental exposures and Parkinson's in the broadest sense. So we get this from epidemiological data. So I will not be able to inform anyone whether any environmental exposures were related to their Parkinson's diagnosis, but I'm happy to provide some information generally about that. And also I'm going to be talking mostly about animal models of disease. So I'm not talking about really any human data here. I'm talking about what we do in the research lab, and just showing you a little bit about how we study Parkinson's, where it comes from, and how we can treat it with animal models of disease. So that's my disclaimer as I start. We've already heard today that Parkinson's is predominantly an idiopathic disorder, and we typically say that about 85 to 90% of Parkinson's is in individuals that do not have any familial form. So some of you may have relatives with Parkinson's, many do not. Typically, we see maybe 10 to 15% of purely genetic or inherited Parkinson's, but for most people, it's idiopathic. And because of that, we think that there are other risk factors that are ultimately instigating the disease. In my research, we think of these as environmental risk factors. I'll talk a little bit more about what we mean by environment in just a slide, in a few slides. But an important thing to note about Parkinson's is it's the fastest growing neurologic disorder. By 2040, we should about double the amount of individuals in the world with Parkinson's. And so this is important for so many reasons, obviously the most important being the human component. If we can prevent any of that, that would be wonderful. And so what my research is trying to really get at is this top component here. Aging is still the most important risk factor for Parkinson's, but are there other modifiable risk factors that we could intervene in to try to prevent some of these cases from starting? Parkinson's risk, as I mentioned, is largely idiopathic, but if we think of those idiopathic disease risks on a kind of bell curve spectrum here, this is just kind of simplified graphic representation of Parkinson's incidence. You can see at one end of the spectrum, we have genetic risk factors. So this would be people with inherited forms of Parkinson's. You might recognize some of these genetic risk factors up here. For example, mutations in alpha-synuclein gene were some of the first mutations that were associated with Parkinson's risk. And you might recognize the proteins LRRK2 or GBA. These are sometimes more commonly talked about now because they're the more common risk factors. Just because you have a mutation in LRRK2 or GBA doesn't mean you will get Parkinson's. So even though you could inherit these risk factors, it doesn't necessarily mean that you'll develop what we call Parkinson's phenotype. On the other side of this gene example are the more rare inherited forms. So PINK1 and Parkin are genetic mutations that can lead to early onset Parkinson's. People who are have sort of a different form of Parkinson's that does not develop in the idiopathic timeline. On the other end of the spectrum, we do have known cases of people who have developed Parkinson's strictly from environmental exposures. This is when we have case reports of an individual who worked with something, or in the case of a synthetic opioid in the 1980s called MPTV, who injected this into themselves by accident. This led to the direct development of a Parkinson's syndrome. So we know that there are examples of environmental risk factors that directly lead to Parkinson's, but most people are in the middle of this spectrum. So you can see that's the way the bell curve works. And we call this gene environment interaction, where you have low penetrance susceptibility genes over a lifetime of environmental exposures, and that is ultimately what drives Parkinson's. Now, this is true of all diseases. This is not, unique to Parkinson's, but with all of these different environmental risk factors for Parkinson's, we think that this is an incredibly important component into understanding how the disease works. So when we talk about what environment means for any disease or any health condition, we call this the exposome. So all of the things you are exposed to in the environment. And when you think of exposome in the sense of the brain or the neural exposome, what we are talking about are all of our genetics. So not necessarily genetic mutations, but all of our genetic makeup, the things that make us ourselves, combined with all of our environmental exposures. This is not just the things that I study in my lab, like pesticides and solvents, but actually this is things like exercise, diet, and all the medications you might take, including some of the things that we just heard about, like psychologic and mood altering medications, things like this that can play a role in our health and disease. So all of these things combine together to ultimately influence any disease, but also Parkinson's. And what my lab studies is in this little bubble right here, the pesticides and solvents. So we take a really direct approach at this, and we actually expose animals to these pesticides and solvents, and we look at neurodegeneration in the dopaminergic system, and we try to understand how that happens and if we can prevent that. So what are the industrial byproducts that I just talked about, or what are these things we put in our environment that can cause increased risk for Parkinson's? This is a list that I generated based on published data. So these chemicals that are up on the screen have to have had at least one peer-reviewed publication in PubMed that suggested that they increase risk for Parkinson's. And so you can see the largest category up here is pesticides. And pesticides have been linked to Parkinson's risk for really since the 1950s. And that's why there's a lot of them, because we've known for a long time that pesticides are associated with Parkinson's risk. We also tend to know where we apply pesticides. So we put them in our crops. We sometimes use them in our garden. But typically for the large scale farming efforts, they have to be registered and regulated. So we tend to know where we put them. It makes it easier to track who's exposed to them. Almost everything else on this list is very difficult to track. So the halogenated solvents, TCE, which is trichloroethylene at the top of the list here. I'll talk about this today. These are used in dry cleaning and in industrial degreasing, heavy metals. There's a type of Parkinsonian syndrome called manganism that occurred in the 1950s from welders that were being exposed to manganese in their welding rods. And then air pollution is kind of an emerging concern for Parkinson's. It's been associated with Alzheimer's risk, but something that we're really interested in looking into for Parkinson's as well. And then up kind of in the corner, not because they're not important, but because they are not considered industrial byproducts, are pathogens and head trauma. These can also play a role in disease risk. And just to kind of repeat back from this slide, it's not just one of these things, it's all of these things that can contribute to risk. So while there are people who have been exposed to things like paraquat and TCE that we think have really influenced their Parkinson's risk, it's everything in our life that ultimately drives disease. So something to consider as I go along. So my lab studies mechanisms of neurotoxicity, and in the most basic form, that means how do chemicals kill cells in the brain. And what I have up here is a picture of a cartoon of some different cells that are involved in Parkinson's. And these include the dopamine neuron, which is degenerating here in orange. This is an astrocyte in purple. These are the supportive glial cells of the brain. And in the yellow, this is a resident immune cell of the brain called microglia. This is a resting microglia that becomes activated. And so that's called part of the neuroinflammatory response. And so all of these cells are important in neurotoxicity. They can all be influenced by different mechanisms that are involved in these environmental exposures that are linked to Parkinson's. So for example, I talked a little bit about pesticides and head trauma, and these can act in different areas in different cells in order to cause neurotoxicity. So just to take an example, one of the things we really worry about inside of a dopamine neuron is their mitochondria. So you might remember that mitochondria are the powerhouse of the cell. Or maybe you don't know that, but you do now. And dopamine neurons really heavily rely on mitochondria. And so if we disrupt their mitochondria, that's one of the ways we could potentially see them die in the brain. And there are a lot of environmental toxicants, I've listed them up here, that disrupt mitochondria. And so that's one of the ways that we look at this from the research perspective is, are there common mechanisms that different chemicals can act upon? And that can ultimately lead to toxicity. So I'm going to talk specifically about trichloroethylene or TCE. The reason for this is partially because this is what my lab studies and partially because it's a really widespread contaminant in the US. If you follow any of the exposure kind of literature or press, you might know that the EPA has just worked to try to ban TCE. That's actually partially due to some of our efforts, as well as the policy folks at the Michael J. Fox Foundation, who I've worked with specifically to be on Capitol Hill and pressing them to ban this compound. And the reason why is because it's a carcinogen. You don't want to be exposed to this because it can lead to cancer, but it's also linked to Parkinson's risk. And we know this explicitly through epidemiological studies, through exposures from individuals who have either worked with it directly or from people who were exposed in their environment. And one of the worst examples of this is in Camp Lejeune, North Carolina, where a group of individuals who lived on the Marine base there were exposed from the 1950s to the 1980s due to a dry cleaner that leached trichloroethylene and some other similar solvents into the groundwater at that military base. And so people were exposed at that military base, and then now almost, it could be 20, 30, 40 years later, some of these people at that military base have developed Parkinson's. And we know that this is happening at a faster rate than individuals who lived at other military bases that were not contaminated with TCE, because the control cohort for this study that was done in 2023 is Camp Pendleton in California. So people at Camp Lejeune have higher rates of Parkinson's due to this exposure. So my lab has been really interested in this over the last several years, and we've worked with different methods of exposure to try and emulate what you would experience if you were exposed to TCE in the environment. So this happens through two major mechanisms: inhalation or ingestion. You can inhale TCE if you work with it directly. It's called a volatile organic compound, or VOC. So it off gases in its liquid form. And if you work with it, you can work with it in its vapor form or its liquid form, and it will off gas. Sometimes people will say it smells sweet. And so that's one way of exposure. Another way would be if these places that use it dump it into the ground and it gets into the soil or groundwater. When it gets into groundwater, it can become a water contaminant, so you could drink it. It used to be considered the most commonly sampled organic contaminant in drinking water. It was once in high levels up to 34% of drinking water in the United States. That has gone down significantly. And now most municipalities will test for it, so you can find out if it's in your water. It's usually not. But the biggest concern is if it's in the soil or groundwater and it's below the building you live or work in, and then that vapor phase intrudes into your house. You can just inhale it. And that's what's happened in a lot of cases. People, live or work over a contaminated site. And so they've been breathing it in for sometimes years at really low levels, and that's led to Parkinson's risk. So this is the main problem we have in experimental research, is we have to take a really complex issue of exposure and a really complex, human system, and we have to distill it down into something we can study in the lab. And so if we take that idea of inhalation and ingestion, how can we model this exposure in the lab in order to get at these questions of how we can, how is this causing degeneration, and also is there any way we can prevent it? So I want to talk to you about the first method we started with. This is trying to emulate if you were drinking it in your drinking water. And we used what's called oral gavage, which is where we just take a syringe with olive oil in it, and we give it to adult rats. And we do this for 6 weeks at a dose, pretty high dose, 200 milligrams per kilogram over 6 weeks. And you can see from the data that's below that little timeline there, that in animals that received the vehicle, which is just olive oil, we have normal, healthy dopamine neurons. This is the substantia nigra right here. And these are the dopamine neurons that degenerate in Parkinson's. This is the dopamine terminals that project to the striatum. And so The substantia nigra and the striatum being the major dopamine circuit, and the basal ganglia degenerates. You can see with TCE, we get a significant loss of these red dopaminergic neurons and a significant loss of their terminal projections in the striatum. And so that indicates to us that just direct exposure to TCE in an animal model can recapitulate the main feature of Parkinson's, which is the loss of dopamine neurons. We can also do this using inhalation. So we take an inhalation chamber and we put rats or mice in that inhalation chamber, and they sit in the inhalation chamber all day, so like 7 hours or so a day. And so they go to work in the chamber for 7 hours a day, and then we do this for 8 weeks. And we use a 50 parts per million dose, which is roughly the OSHA level of exposure. So OSHA comes into your workplace and you work with TCE and you're being exposed to 50 parts per million, they'll say, well, that's not over our limit, so that's fine, you can go back to work. Although most people are not exposed to this, again, we've done a lot of work to remove TCE from the workplace, so this might be more of a historical exposure. The point remains that this causes the degeneration of dopamine producing neurons in these animal brains. And so you can see the dopamine neurons here. This is the same stain as in here. This is just not fluorescent, it's called chromogenic. So they appear brown. And then the fluorescent loss of dopamine terminals in the striatum. So you can see nigrostriatal neurodegeneration when we treat with either ingestion or inhalation of TCE. So this is really important because this is the main way that we start to study this. We have to confirm that we lose dopamine neurons when we recapitulate these exposures. So a little bit more about what happens when we feed TCE to animals. I just showed you that we cause loss of dopamine neurons. We also see loss of spontaneous locomotor activity. You can see in these trace plots here of animals that have been placed in what's called an open field chamber. They have decided not to move very much. You could imagine that that makes sense if they have lost a lot of their dopamine producing neurons. Some more data here just showing that we've actually lost the cell bodies. Really, the take home is that we see similar Parkinsonian type behavior from these animals that have been exposed. So when we see this, we think, okay, great, we can kill these dopamine neurons with this TCE, but how does this happen? We still don't really know what causes these dopamine neurons to die in human brains. And so the way that we can get at that is by studying how they die in these animal models of disease. And so I talked just a bit ago about mitochondria being a really important part in dopamine neurons. And one of the things we think TCE does in the cell is it targets the mitochondria and causes dysfunction. And so what you're looking at in these fluorescent pictures here are dopamine neurons. That's what's in red. TH stands for tyrosine hydroxylase. That's the enzyme that produces dopamine in these neurons. In case you're wondering why TH is being repeated in all of these images. So TH is just a dopamine neuron marker. And what you can see in the bottom panel, which is our TCE treated rats, top panel is vehicle, that we get an accumulation of mitochondrial damage. And so you're seeing oxidative damage in white and in cyan here. And these are two markers with really long names, 3-nitrotyrosine and 4-hydroxynonenal, which are just fancy names for saying oxidative damage to proteins caused by mitochondrial dysfunction. And so this was a really big sign for us that TCE is probably acting at the mitochondria, and that could be one of the ways it causes toxicity and ultimately could lead to dopaminergic degeneration. Another mechanism that we're really concerned about is what's called lysosomal dysfunction. The lysosome is the part of the cell that degrades protein. And you might know that in Parkinson's, there is also an accumulation of the protein alpha-synuclein. This is what forms Lewy bodies. And if you can't break down the protein in your cell, then you may have accumulated protein, and that could form Lewy bodies. And what we found, again, through looking really closely at these dopamine neurons, in this case, green in this image, they're blue in this image, and they're pink in this image, because we like to use as many colors as possible when we're studying these fluorescent images. You can see from this that we have a breakdown of lysosomal function. So I'm just going to show you, for example, in this last panel here, in the pink neurons, pink purple neurons, this yellow protein called LAMP1 actually stains the lysosomes. And you can see, I think, pretty clearly that there is a loss of lysosomes in that image. And so this is what is really critical when we study this. You know, we see oxidative damage, we see loss of lysosome function. These are really core pathologies in what we think precedes dopamine neurodegeneration in Parkinson's. And so being able to recapitulate that with an environmental exposure tells us that this is likely how this is working. Okay, so we set up the stage, we have pathology, we're looking at these specific mechanisms, and now we have to ask the question, how do we get Parkinson's from a TCE exposure? So if a lot of people in the world have been exposed to TCE, but not everyone has developed Parkinson's from it, why could that be? One of the reasons is because not everyone's exposed to a large amount of TCE. So people on this end of the spectrum that get exposed to a lot of TCE, like the people at Camp Lejeune, they may develop Parkinson's without other risk factors. But if you develop Parkinson's and you haven't been exposed to a lot of TCE, you may have a genetic risk factor that could be interacting with that exposure that ultimately leads to you getting diagnosed with Parkinson's. And so I'm going to talk a little bit about this gene-environment interaction that we looked at with the commonly inherited Parkinson's mutation LRRK2. I say commonly, it's not very common. It's about 1 to 2% of Parkinson's cases overall. But LRRK2, you hear a lot about. There's a lot of reasons for that. One is that we have good genetic testing for it now. Another reason is that there are currently therapies going through clinical trials to try to reduce the impact of LRRK2 in the effect of Parkinson's. And so just a quick science background for you. LRRK2 is what we call a kinase protein. It phosphorylates things in the cell. Really, that just means that it coordinates things by putting phosphogroups onto other proteins. That's a little bit complicated, but the most important thing to remember is we call this a gain of function mutation. So when it's not working well, it's actually increasing its kinase activity, which is unusual. Most mutations mean a protein is not working, and this one's working too much. And so we try to reduce that kinase activity to improve LRRK2's function. So how do we do this in the lab? We used our animal model of TCE ingestion. We gave them TCE for 3 weeks, and then we treated for another 3 weeks with a compound called MLI2, and this is what reduces LRRK2 kinase activity. So it's a pharmacologic little compound that we can dose. We just give it with oral gavage the same way we give TCE. And what's nice is that LRRK2 kinase inhibitors are currently in clinical trials, and so this is very similar to what's going on in human populations as well. So I showed you this earlier that we could see oxidative damage from the TCE, right? So this white and cyan color here. And when we treat with MLI2, so you're looking just in that bottom row there, we get a total reduction of that oxidative damage. And so you can see that these cells no longer have what we think is mitochondrial dysfunction or oxidative damage that could be driving the neuron loss. What about that lysosomal dysfunction I just talked about? So I showed you LAMP1, which is reduced. In this case, it's in green. So you see dopamine neurons in red, you see green is LAMP1, and you see now this time alpha-synuclein, the protein that makes Lewy bodies, in purple. And in TCE treated animals, in this third panel here, you see a reduction of LAMP1 and an increase in alpha-synuclein because it's not being properly broken down. And when we treat with MLI2, you can see that we can rescue that effect. So you see an increase in LAMP1 and a decrease in alpha-synuclein. So this is overall a really good thing, right? Because we can protect against the mechanisms we think are driving this toxicity. And so the main question is, does this save dopamine neurons? And the answer is yes. When we treat these animals that receive TCE with this LRRK2 kinase inhibitor MLI2, you can see with just TCE alone, you get a loss of dopamine neurons, but that's rescued with MLI2. So this is an example of how we use a therapeutic in the lab to try and assess whether dopamine neurons are potentially able to be rescued from environmental toxicity with a therapeutic. Okay, so that was just kind of a little summary on the side. I just said that verbally, so no need to read through that. So for the remainder of what I'll talk about today and what the work we're doing that's funded through APDA, we're asking a question that I think was really nicely addressed today, which is that Parkinson's is not just a movement disorder, it also includes a lot of non-motor symptoms. And one main symptom that we're really passionate about is understanding cognitive impairment. So one question we ask in the lab is, do environmental exposures not just affect your risk for Parkinson's, but can they affect the type of Parkinson's you have? So can you have more cognitive impairment or other non-motor symptoms depending on what you've been exposed to, and how does that shape Parkinson's? So most people with Parkinson's, as they progress, may develop some type of cognitive impairment. We develop that as we age in general, so that makes sense. And so, you know, what we're trying to ask here is, would people who are exposed to TCE have that effect be worsened? So would they have more cognitive impairment than a person who was not exposed to TCE? So this is a APDA funded project done by my graduate student, Ashley Adamson, who is here today with me. And so if you have any questions about this, you have to ask her, because I know nothing about it. She has done this whole project herself, and she's the one that you can ask questions, especially if you don't understand anything, because she's great at explaining everything. So the way that Ashley did this is she put animals in the inhalation chamber. So we're not using gavage this time, we're using inhalation. Caused dopamine neurodegeneration. You can see that again here. This time she's using mice, not rats. So fun little distinction. And what she found was that these mice develop Parkinson's-like symptoms, which is, in this very large series of graphs, the loss of dopamine neurons, as well as the loss of motor function. So that's what these graphs through E through L mean. So that's a motor test that we do in these mice. It really means that their gait isn't quite right, and they look a lot like how you might present when you first go to the clinic, which is asymmetric gait disturbances. They had slowed movement, but overall it was pretty mild. We also found that these mice had a loss of memory function. And so this is a test called the Y maze. You can probably see why that is. And animals that did not receive TCE, they explore this Y maze normally, but animals that do receive TCE exposure, they have an issue with going into what we call the novel arm of the Y maze. And so you can see that in the graph. They're no longer exploring the novel arm, which means that they've lost a specific type of memory, spatial or working memory. That's corresponded to a part of your brain that you might have heard of called the hippocampus. This is where a lot of memory is stored. This is what's affected in Alzheimer's disease predominantly. And so you can see from our purple cells here that you can hopefully appreciate there's actually a loss of these cells in the hippocampus. So we're actually talking about cells outside of the substantia nigra now. So these are non-dopaminergic neurons, and they're also reduced with TCE exposure. And so we're asking now, so maybe people who are exposed with TCE could have worsened cognitive impairment because it also affects another part of the brain, the hippocampus. And so one of the things that is important in Alzheimer's and Parkinson's pathology, this gets a little complicated now because I'm talking about what's called co-pathology. So, you know, if you're a person with Parkinson's with a lot of cognitive impairment, you may actually be sharing a lot of Alzheimer's or dementia features. And in the brain, we look for that pathologically as the accumulation of protein involved in dementia. And one of those proteins is called tau, so TAU. And when tau becomes improperly phosphorylated, it can accumulate. And so the main question we're asking here is, does TCE cause accumulation of tau in addition to synuclein? And could that be driving this cognitive impairment that we see? Could that be driving this hippocampal neuron loss? And so what Ashley has investigated is the levels of tau within the hippocampus of these animals exposed to TCE. You can see this in the beautiful picture up here. In vehicle-treated animals, we see a normal level of phosphorylated tau. It is a protein that's in all cells. It's working normally in these control animals. But you can see in the bottom panel that it's really accumulated. And this is because it's not being either degraded like synuclein, or because it's being phosphorylated at too high of a level to be maintained. And so that's this accumulation in the hippocampus here. So Ashley asked the question, what phosphorylates tau? And there are a lot of things, but one of the major things that phosphorylates tau is this protein called cyclin-dependent kinase 5, or CDK5. And you know, it's involved in a lot of things in the cell. It's mostly in neurons, and we know it's involved in cell cycle regulation, but your cells don't really divide in the brain. So what is it really doing in these cells? And we know it's also hyperactivated in brain tissue from people with Parkinson's. And so what we were wondering is maybe TCE actually causes this CDK5 to become overactivated like it does in these disease states, and that could lead to this phosphorylation of tau. And so the way that we measure this is by measuring its downstream activators. So we measure this protein called P35 and P25. The kind of complicated version of this is that when CDK5 is not activated, it's in the cytoplasm, and then P35 and P25 tell it to go to the nucleus in order to transcribe CDK5. The simple version of that is when you get an increase in P25 or P35, CDK5 is activated. So what do we see in brain tissue of animals that have been exposed to TCE? We see elevated P25, P35, and that suggests that we have increase in CDK5 activity. We also see that CDK5 proteins, P25, 35, are not in the cytoplasm anymore. They go into the nucleus. So in this picture on the right, you can see a neuron. This is a neuron within the hippocampus in red. And this green is P25, P35. And you can see it's not in the nucleus. That's this blue part here. But when we look at animals that have been exposed to TCE, this P25, P35 is in the nucleus here. So it does in fact cause it going to the nucleus. It's probably overactivated. And so we were asking the question next, can we block this in order to prevent that tau phosphorylation and hopefully to prevent that loss of hippocampal neurons. So instead of like what I had for that really lovely picture with MLI2, the LRRK2 kinase inhibitor, this project is still ongoing. We just started this in September of last year. So I don't have the animal study data from that just yet, but I can tell you in cells, we can block this and prevent tau from accumulating. So in the top panel, these are cells, or I should say in the left panel, these are cells that have been treated with our vehicle. TPE is in the middle, and then TCE plus inhibitor that prevents CDK5 activity. You can see that p-tau is reduced. That's in green. So in the middle panel, we get increase in p-tau with TCE exposure and a decrease with our CDK5 inhibitor. So the way that we do this first in the lab is that we need to try an experimental drug. So Ashley's been recently doing this. We've exposed these animals and we're treating with this CDK5 inhibitor called TP5. Animals get this every other day. She injects this into them. And then at the end of the study, we're going to look at their neurons and see if we can protect against this neurodegeneration. We're also going to see if we can protect against cognitive impairment. And I don't have that data, like I said, because this animal study is not finished yet, but some early data tells us that we have reduced CDK5 activity. And so you can see in this called a Western blot on the right-hand side of the screen, in the very left column, that thinner band means we have less CDK5 activity. So this is an example of how we go about understanding both mechanisms of toxicity as well as therapeutic development. So could we develop a CDK5 inhibitor that could be used to potentially prevent some of the cognitive impairment in Parkinson's? So kind of to summarize, our work with APDA is asking the question, if you are exposed to an environmental toxicant like TCE, and if this impacts CDK5 activity, could this cause phosphorylated p-tau accumulation, leading to hippocampal degeneration and cognitive impairment? And can we reverse that by inhibiting CDK5 activity? And so I'm really excited for that work. I'm really grateful for the APDA for funding this so that we can hopefully have this answer when the time of this grant wraps up. Okay, so this is my key takeaway. Again, not really, you don't really need to read through all of this. It's mostly just what I've said. Environmental exposures are really important in Parkinson's, and they can influence the way that a person may experience Parkinson's. And that's something that we just haven't understood very well in the research community. And that's what my lab's really focused on. And so for the last slide here, I will just talk a little bit about the question I always get asked, which is how do you prevent environmental exposures in your home, in your community? So the map at on the left is from a website called the Environmental Working Group. Anybody can go there to look. This is TCE that's been found in drinking water at levels that were considered unacceptable. You can see most major cities are on this list. It's really not a big deal right now. It used to be worse. If we looked at this in the 1980s, it would have been much worse, but if you're really worried about this, one thing you can do is you can filter your water. So reverse osmosis or granular activated carbon filters like a Brita filter can filter this out of water. Important to remember that it's not always just drinking water. Sometimes it's contaminated sites. Usually, you know, if you live over a site of TCE contamination because it's been evaluated by the EPA, but there are cases where you may not know. And so it's important to sort of be informed about what's in your environment. And TCE is just one thing. You can look up pesticide exposure by looking at what pesticides are used in your community. There's a resource by the USGS that looks at pesticide exposure in different areas of the country. And then we can influence policy it's just, I think, a really important thing at the level of local or federal government to try to ban these things that are neurotoxic. And I would also argue are probably carcinogenic as well, to try to reduce our exposure to them. So I have a couple of resources up here for individuals. If you are interested in learning about what contaminants are in your environment, you can look at atsdr.cdc.gov, or you can go on a Google search. I would just highly recommend staying on federally sponsored websites. You don't want to go into a rabbit hole of people who think that they sort of know where toxicants are in the environment. That's, you know, you don't want to be worried about this stuff that so much of it interferes in your daily life. You want to make sure you have an informed decision so that you know if you really need to take action against anything. This is a nice little graphic from a paper that we published a couple of years ago showing that we think that environmental exposures really need to be better integrated into Parkinson's research. I talked to you today about how Parkinson's is idiopathic and that there are a lot of risk factors that can affect Parkinson's risk. We just don't do a very good job of researching that. So the APDA is one group that's supporting us to do this work. And I would encourage you to, if you are interested in this, to make sure that you think other people should be studying this as well. And so this is something that we're really passionate about. Feel free to look up this paper. It should be available to you online. And if not, feel free to email me and I can send it if you want to learn more. So just to thank my lab and my collaborators, there's a picture of the mouse or rat in the inhalation chamber. This is not a real rat, don't worry. It has 3 eyes, that's why. You're probably wondering what's going on there. And a huge thanks to my lab. I have a lab full of really talented women who are really driving this work forward. And I think it's so wonderful to see them learning and growing in this and becoming passionate about environmental exposures and Parkinson's. And one of the requirements to be my graduate student is you have to have blue hair. So you'll see that that's a part here. But I'm really grateful to be here today. Thank you so much for letting me take the time to talk and happy to answer any questions.
All right. Thank you so much for that great presentation. Does anybody have any questions? We'll take about 2 or 3, then we'll pass some information about lunch.
Awesome presentation. I have a question about TCE. You mentioned that it actually is used in dry cleaning and it was basically identified that way.
Yeah.
Are there any communities that work in that business particularly that have been studied, and is that something that's being looked into?
Yeah, that's a really good question. There are no formal epidemiological studies on dry cleaning as a profession and Parkinson's risk, which is really, I think, a missed opportunity. I believe that there are certain efforts right now to do that. Thankfully, TCE is not used as much as it was in dry cleaning, again, because of that cancer risk. But a very structurally similar chemical, tetrachloroethylene, so just has one more chloride residue than TCE, is really commonly used. And so it's not clear to me if that will remain as a Parkinson's risk factor in the dry cleaning industry, but I would love to see that study be done. I'm certainly a proponent of it, and I hope we can get that data before these people who use this in dry cleaning are no longer with us. So yeah, really great question.
In the Parkinson's community, for the sake of accuracy and terminology, I'd like to know if we can do something to what seems to me to be a correct need for correction when we talk about pesticides. It looks like to me we're also dealing with herbicides, but yet we always talk about pesticides, and it may be leading people to think that it's only that and not herbicides. So can you comment on that?
Yeah, I'm happy to. Really great question. So is a lot of terminology underneath the pesticide category. And so the way that we sort of officially talk about this in the toxicology community, and this is more on the scientific side, a pesticide is sort of an umbrella term for any product that kills unwanted bugs, unwanted weeds, unwanted mold. So a pesticide is an umbrella term. An herbicide specifically targets weeds, right? So paraquat is an herbicide. Roundup is an herbicide. There is insecticides that kill bugs. We also have fungicides that kill mold. So yes, there is a lot of terminology, and I would argue that paraquat, the herbicide paraquat, is the one that we see the most data on right now in terms of Parkinson's risk. So that would be a critical herbicide to know is important, but the umbrella term of pesticide is used for all of those things. So a great thing to clarify.
For an idiopathic, Parkinson's person, if they have been, exposed to a chemical that in the environment, is there a way other than autopsy, perhaps? Yeah, so find out what
Yeah, that's another really great question. The short answer is, I think, kind of the difficult one, which is no, you really sometimes cannot tell. And the main reason for that is because most Parkinson's occurs many, many years after the exposure happened. So it could be 20 or 30 years after. That usually by that time, you would not have a chemical inside of your body. Like, so if you take TCE, for example, people who worked at Camp Lejeune would have lived and worked there like 20, 30 years prior to the onset of their Parkinson's. And so we can't really go back and look in their blood, or in their tissue. There are some cases that have come to autopsy that have shown that people may have, chemicals in their brain. It's not the most convincing. So we rely on epidemiology right now to do that. There is strong epidemiology showing risk for Parkinson's from things like TCE and paraquat. Sometimes heavy metals stay in the body longer, but that data is a little bit hard to get. So what you're asking is really the next phase of where we need to go with research. We need to develop better monitoring so that we can understand when people are exposed to things and sort of keep that as you could envision maybe a log of exposure that someone's had. We could use that data to determine whether or not that could be either predictive of a Parkinson's diagnosis later, or potentially, how that might happen. So I would really love to see that, and I'm very hopeful that our friends in the analytical chemistry world can start to produce that. One really cool thing that's happening right now is there's a project out of Emory where people are wearing silicone wristbands, and they're submitting that into a science lab at Emory, and then they're taking the compounds that have been absorbed into those wristbands, and they're determining the exposome of these people, all of the things they've been exposed to. So it captures like everything in a week that they're exposed to. Data like that is what's really going to start to help us get at that question. I don't know. Oh, she did. Okay. You next. Sorry, I think the microphone's not on.
Non-essential tremors.
Sorry, what about non-essential tremor? Can I explain them? So, no, because I am a research scientist who's studying TCE toxicity. No, so if the question is non-essential tremor involved in this type of exposure, we don't have good data suggesting that essential tremor is influenced by these environmental risk factors the same way Parkinson's is. It's a different type of degeneration in the brain, right? So that's one of the reasons why we don't think it's involved. But could an environmental exposure impact non-essential tremor? Potentially. We don't have data on that yet. I wish we did. This is an example of how badly we need this kind of research, I think. It'd be great to know. But yeah, that's about all I can tell you about that, simply because we don't have that data. And we don't see that in our animals. They don't get tremor. We can't reproduce all the features of Parkinson's in a rat or mouse, unfortunately. Yes.
Yeah, there are a lot of solvents other than trichloroethane.
Mhm.
defense manufacturers use methyl ketone by the barrel. You study that.
The question was, do we study other solvents that are like TCE? The answer is yes, but with a limited amount. So we haven't been able to study, we've studied tetrachloroethylene a little bit. It takes a really long time for us to develop these animal models. What the data I showed you today took almost 5 years to generate. So we'd really like to develop like a screening platform to build in these structurally similar solvents that we know are used in really wide quantities that could be linked to Parkinson's, but we don't have the data on yet. And so one of the things we like to do is look at, like, instead of using animals, using cells to do that. And so that's one of the ways that me and my collaborators are working together. So sadly, I don't have information on that today, but again, I hope that's something we can move into and something I'd really like to do in the future. Thank you for that.
Well, thank you so much, Dr. Dean. So it is now time for lunch. Before you guys stand up, Joe's gonna go over our instructions and how we're gonna break down lunch so that we have a smooth policy in terms of distributing our lunch in our breakout rooms. So go ahead, Joe. Or Catherine.
Hello, one quick announcement. First of all, I'm Catherine. I'm the chicken you've seen running around with no head. Welcome, thank you guys for coming. We have found the medication. If anyone is missing it, please come find me and let me know. And that is my announcement. Joel, take it away.
Wonderful. Thank you, everyone, for coming here. For lunch, outside these doors on the main table, you'll see chicken, and turkey, and then vegetarian. Here along this hallway, you'll have your gluten-free options. Take your food. We have about 35 or so minutes, eat them to satiate your hunger, which I'm sure you all are feeling. And while you're doing that, also migrate to your desired breakout room as well. It'll be swift. There's a lot of us, so hopefully we don't bump shoulders, and we are away.
For those who would like their lunch passed, if they're not comfortable standing up or would rather have someone bring their lunch to them, simply raise your hand and we will have our volunteers bring you your lunch to make it a little bit easier on you. And then also, if anyone registered as gluten-free or vegetarian, I will be right outside this door by the drink station to claim your lunches. But if anyone is in need of assistance or would like to have their lunch brought to them, please raise your hand and our volunteers with the yellow lanyards will come ask you if you prefer turkey or grilled chicken, and they will bring your lunch to you.
Where are they going for the family question? Is it this room? This room?
I just went to Virginia and I've been kind of figuring out around
Very confident. Again, just like what Dr. mentioned, it comes together. We believe that the player role is activating other things that we may have in multiple things come together. Like that. That is very helpful. I think that your brain has something. If you have one concussion. I have some questions. First off, I want to say not that I'm excited about it, but I had a question. Because I was concerned on the manufacturers required, not the military. And I actually got a few of and I was wondering if yeah. There's something, I think Dr. Kirin has just briefly. They have the origin something is really they have to be able to have one machine we have looked at the different viruses and some groups are we have we haven't seen any we don't have any clear evidence that however, if and then I had one of and during your so like new patient, remember I think Dr. Sarah Latin. Yeah. These ones who are so we're actually it's possible that you might respond to you can also be told that you involved in their own. And then if you prefer something to get, you also so after that, we have how things work. Exactly. Down the road, I wasn't sure when I come to her. She sounded very specific, especially pesticides, and I was like, oh, you're more conditioned, so you might have more knowledge. I appreciate your time, sir. And make sure you keep something. Sure. And just stand around here.
Means that 9 almost 70.
Has everyone received their lunch? Does anyone need help with their lunch or anything, drinks wise, food wise? Everyone have all their food? Please raise your hand if you need any assistance with drinks or food. We have volunteers who are here to help you.
Oh, really? Wow. Thank you very much.
It's ordered them, but it's a walker, that's they're not over. What conditioning stuff. Usually it's very good. Had to, more older style like this there. Mom and dad. We need over this one. Well, we have. We finally interviewed and we didn't even know how.
Hello, everyone. Just one quick announcement. We're going to be starting our breakout sessions in about maybe 10 minutes or so. So please start thinking about where you'll be meeting next. We have our panelists for our Live Well with P discussion here, and in the breakout room, we'll be having a discussion about clinical trials with BCU. So please start thinking and making your way to your next breakout session. We'll probably get started in about the next 10 minutes or so. So no rushing, take your time. But if you're done eating and don't want to start moving, feel free to do so.
How many of these do you do? Have you done?
You know how that goes.
Okay, no worries.
Hello, everyone. So we're going to go ahead and get started. I just want to reiterate that this room is for the breakout session for Living Well with PD. There is another breakout session happening at the same time with Ginger Norris from VCU's Parkinson's Movement Clinic about getting involved in clinical research. So if you would like, if you're in this room, we're going to go ahead and get started with Living Well with PD with our panel discussion. If you're interested in learning more about clinical trials, please make your way to the exit, and there are volunteers in the hallway who will be able to help you in the right direction for the breakout session.
Yeah. I get the middle half is my name, I don't want to show. I get the middle name, I get everything.
Just want to reiterate that this room is for a Living Well with PD discussion.
Don't call me Ken.
Our breakout session for research and clinical trials is straight down the hallway. If you have any questions, our volunteers with the yellow lanyards can point you in the right direction. All right, everyone, we're going to go ahead and get started. You're more than welcome to continue eating during our breakout sessions. Please don't feel rushed. We're going to go ahead and get started. So I am pleased to introduce our moderator for our panel discussion, Live Well with Parkinson's Disease. We are grateful to have our healthcare providers or professionals who can educate the Parkinson's community. However, sometimes it is best to hear and learn from the Parkinson's community itself. Today, I'm happy to introduce Ali Signorelli, who is a fundraiser and event producer who has spent close to 25 years raising funds for nonprofit organizations across the country, working with everyone from CEOs to first ladies to A-list celebrities. She has generated millions in critical revenue for vital causes during her career. After being diagnosed with young onset Parkinson's disease in late 2022 at 47 years old, Ali channeled her expertise and experience into raising awareness and funds for Parkinson's research. A vocal advocate from the start, she has grown a substantial online presence through her Instagram account at I'm Still Ali, where she has built a community of nearly 50,000 followers, many of whom are living with Parkinson's or are supporting a loved one with their disease. Her content has reached more than 40 million people in the past 10 months, and she regularly hosts live interviews with well-known voices in the Parkinson's and brain health communities, who share important information about prevention, as well as tips and ideas for living a full life with Parkinson's disease, or with a chronic disease. She is a graduate of Northwestern University and an active member of the Arlington, Virginia community, where she lives with her husband, Mike, and 2 children. I would like to also introduce our panelists from today. Susan Burns from Power Parkinson's in Richmond, Virginia. Joseph Ferguson from Ivor, Virginia. Kenneth Canopy from, okay, good, okay, from Richmond, Virginia. And Lori Graham, author of Parkinson's Disease, Now What? A Guide for Patients and Caregivers. So please welcome our panelists and Ally for a great discussion today.
Hi, everyone. Thank you for staying in this room. I was really afraid everyone's gonna get up and go listen to Ginger, but I'm really excited to be here today. I, as Naomi said, was diagnosed in December of 2022 with young onset Parkinson's. And part of my living well with PD is trying new things. So this is the very first panel discussion I've ever moderated, so I know you'll go easy on me today. I'm gonna kind of awkwardly stand here and try to moderate. I'm gonna hand over the handheld mic in a second to let everybody introduce themselves more in depth. Excuse me. And at the end, we'll save some time for questions. So as we're going through the discussion, if you think of anything, just hold on to it and we'll take questions for about 10 or 15 minutes at the end. So with that, I'm going to turn this over. I think this is on. Rory, do you want to start? Tell everybody a little bit about yourselves and then we'll start. Nope.
Testing, that on now? Yeah. Yes, okay. All right. My name is Rory Graham. I live in Chesapeake. My wife had Parkinson's for 23 years, so I was a caregiver, say professional caregiver. I learned an awful lot about the disease. Early on, I got involved, we both got involved with the organization, APDA. President for 3 years of the Hampton Roads chapter. My wife and I were both on the board of directors, and she ran a support group in Virginia Beach for about a decade, and co-run it. And so we saw a lot of people who had Parkinson's, so of course she did. So after her passing in 2022, I wrote this book. It's Diagnosis Parkinson's Disease Now What? And it's for patients and caregivers, because I feel that in my journey and people that I met, it was knowledge is power. And you guys are great, getting a lot of knowledge here this weekend. But knowledge is power, and the more you know about this, the more you can deal with it and help have a better lifestyle. So it's something caregivers need to do too, because they need to understand what the patient's going through. So anyway, I'm glad to be here.
Hi, I'm Susan Burns, and I was diagnosed in 2012. I had symptoms that showed in probably 2010. And every doctor I went to thought I had something wrong with my foot, or, you know, it was always something. When I finally was diagnosed, I went to a neurologist, and I called that neurologist Dr. Kirin, because he was very short with me, gave me a prescription, he sent me on my way. And I was in a total shock. So I think if you listen to us today, we can help you deal with your Parkinson's, or deal with your caregivers, learn to deal with people that have Parkinson's. But I think that this is a good open event to bring awareness to Parkinson's. Community, I think, is not knowledgeable about Parkinson's, and I believe in April it's Parkinson's Awareness Month, and we want people to know and understand what we're going through. So anyway, I'm glad you're all here and hope you can learn something.
I'm Ken Canopy. I was diagnosed in January 2017. My symptoms began in the summer of 2016 at the age of 54. This was a total shock to me. I worked out, I exercised, I took care of myself, and it came out of nowhere. I believe it's environmental because no one in my family has it, or had it, I should say. Once I found out that I had, well, actually, I'm an analyst by trade, so I at the gym, I had some of the trainers check me out. Why did I have a gated walk? Why was I shaking, trembling? What was going on with me? So I finally went to the doctor in January 2017. Meanwhile, I looked at the websites, WebMD, my doctor, regular doctor said to me, I believe you have Parkinson's. And I said, yeah, I know. I went to WebMD. Now, he wasn't too happy about that. We got along pretty well. So he sent me to one doctor, who was an older doctor of practice, I should say. And he was a general neurologist. And he said, take these pills. And if your symptoms go away, you have Parkinson's. It didn't sound very appealing, but I was gonna go ahead and try it. So I did that and I came back and he said, well, I guess you have it. And he suggested immediately I go to VCU Health. And I said, well, wait a minute. You just told me I have Parkinson's. I need to digest this for a little bit. I need to do research. And 1 year later, I went to VCU. And it's been great ever since. I exercise at least 4 days a week, maybe 5. There's a great community in Richmond for exercise and just to get out and socialize. A couple of different groups I belong to. It allows me to, see what's going on with me, to tell other people what's happening, what I'm doing. I also belong to 2 different gyms that are designed for Parkinson's patients. One, I was there, I took a class soon after I found out I had Parkinson's, and I met up with a gentleman that started the POP organization, which has been extremely helpful to me. That's about it at this point. I'm sure I'll be speaking again here in a minute. I just wanted to give you an overview.
I'm Joe Ferguson from Smithfield, Virginia, and I was diagnosed in 2018 at 56. And prior to that, that was at the Centera operation in Virginia Beach. Prior to that, I had a tremor in my right foot, and I was driving my state vehicle where I worked for 24 years, and I was having problems keeping my foot steady on the gas pedal, and it actually felt like I was actually tapping on the gas while I was trying to drive. Of course, that wasn't good. So I mentioned it to my regular GP doctor for my annual physical, and he referred me to a regular neurologist. And I went there, and for I think it was 8 months, he told me to take this, and that didn't work. And he told me to take another thing, that didn't work, and so on. And when I first went to him, I said, "You don't reckon I have Parkinson's, do you?" Because my dad had it. And he said, "No, it's just tremor. We're gonna fix your tremor with the medication." Well, it didn't work. After 6 or 8 months, I don't remember exactly, but it was a long time. I finally wrote him a letter in the mail, sent it to him, and said, "This isn't working. I'm fed up with this. I want something different." So he referred me to the MDS at the Centera operation in Princess Anne, Virginia Beach. And in just a few minutes, she knew what she was going to say to me, and she led me through this logical explanation. And I could see before she even got to the conclusion where she was going. And so she said, "Yes, you have Parkinson's." And so I worked for about another 1.5 years with the state. And at that point, I had a confrontational job. I was a food inspector for the state, and going in all the grocery stores and investigating sanitation, food safety, and such as that. And that was a very confrontational thing. People would look at me when I was trying to give them my report when I finished my inspection, and they would say, "Are you cold?" They would say, "Are you scared?" But they didn't know because I was hopping and bopping. And I said, "No, I'm fine." But that nervousness with confronting people on a daily basis, I couldn't keep doing this. So 1.5 years later, I went on disability. And here I am. And I've delved into the research, and we're so fortunate today to have the internet, which previous generations with this situation that, didn't used to have. But we can learn so much, and I've been very involved the first at least 4 years. I think I'd be comfortable to say that every day I was reading every day something in my research. And I believe that people sometimes say, well, don't read, you get all nervous, it'll make you worse, you get scared at worse. I believe in knowing the enemy. I'm an old army soldier, and I believe in knowing the enemy. So if you know your enemy, you're better in a position to resist your enemy and defeat your enemy if it's possible. This may not be possible, I understand that, but it's the same principle. So I've done a lot of research and reading constantly, but I believe it's important not to put trash in. Make sure if you do that, the critical difference is you must discriminate what information you even look at, what even you read, because eventually it all blends in your brain and you won't remember where you read what. But if I believe that if you put good stuff in, you'll only have good stuff knowledge-wise in your head. So I therefore look at things only that come from .edu, .gov. So that means, government and universities, and many of those universities sponsor professors who know what they're talking about, researchers, doctors. So I just read the really credible stuff as an original source that I trust. And if it's some other mess, I just don't even look at it because I don't even want it in my head because it'll confuse me, and I understand that. But I do study this hard, and I belong to several support groups that I've been involved with since before COVID. We had one over here at Newport News at Riverside, and then unfortunately this past year they restarted that. I helped start one in Smithfield, which we just had our year anniversary. Connie's up here, co-founder and leader, and we've been very successful with that. So when I first got it, I thought I might want to try to start a group, and then I found out the doctors wouldn't tell you who the patients were in your community because of HIPAA. So I just eventually said, it's not going to happen. But I remember Connie was a stranger to me, and she said, I'd like to start one. Would you help us? And so I said, sure. So we did, and it's been very successful. I encourage you all, if you don't have one in your community, it's not that hard. We'd be glad to talk to you about it. But you want one, make it happen. And we're thankful, and we have some other ones in this area on the peninsula that I participate in from time to time. And I get a lot out of that. And I love sharing what I've learned. It's just something, it just makes you feel good that you can help other people who are your peers in an unfortunate situation like this. And so I'm thankful to have that opportunity.
Great, thank you. I'm gonna start calling it hopping and bopping from now on. Whenever I'm feeling tremory, because that sounds a lot more fun. You can hop, right? Well, thank you all. It's amazing how many shared experiences we all have in the diagnosis process. I'm sure all of you have too. It really doesn't matter what age you are when you're diagnosed with this disease. It seems like we've all had the same path where we were told it was one thing, just kept in bay, kept at bay, and we'll keep it on track, and then all of a sudden you get the Parkinson's diagnosis. And for me, it was slightly terrifying, I'm sure for many of you. But it's great to hear and see so many people doing so well farther into their journey. So thank you all for being an inspiration to me. Susan, I wanted to start with you. I read online that when you were diagnosed, you joined a support group that had men and women that didn't seem to meet your needs, the specific needs of a woman who was diagnosed. And so you, I think, started your own or created some programming for women with the disease. What did you find in that process, and sort of what is unique to your experience as a woman with it?
Well,
I think you just gotta hold it real close, it seems like. Can you hear him?
Yes.
Yeah.
okay. I think, I found that when I went to the NIST group, there was a lot of poor people, and what can I do or can't do? There's a lot of complaining negative, and to me, I think that's, if you have a negative attitude with Parkinson's, it just makes Parkinson's worse. So I do try to have a positive attitude. And I've decided that with women, we have different needs. We're supposed to be the caregivers. We're the ones that take care of the family. We're the ones that help people. So it was a reversal, I had to have somebody take care of me now. Could I accept that? It was difficult to come to grips with that. So I started a women's support group and we got rid of the whiners and I don't need to drink. It was very successful and actually, Dr. Letterman assisted with that. And it's still going on. I was the facilitator for 6 years. And I went to a facilitator class up in Baltimore. And what happened was I had a really bad bout with Parkinson's and I was pretty much bedridden for about 6 months. And I couldn't get out of it and finally I gave it up to BCU, decided to take it over the group. And it's still going on. And the Broad Street Now Center, if anybody knows where that is, it's the neurological center, movement center for BCU. So I'm very happy that they did that. But I think that everybody has to find their own niche, you know, just like you have to find your own medication. Everybody's different that has Parkinson's. But I think that this Parkinson's support group that I started, it was basically, you can go to anywhere on the web and get information. So it wasn't going to be an educational type situation. Started it as a place for women to go and find fellowship and help each other and share our experiences with each other. It was a huggy-feely kind of support group. And we have things like we have show and tell and bring things that helped us on our daily life that we could share with our fellow parkies. And it was fun, you know, to do that. And we did a lot of sharing our problems with each other and that we could help. Like if you had a problem with something, somebody would step in and we had sympathy for each other and compassion. So I think it's a great way to have a support group. I've never been in one like that. It's always an education type situation. And so it was very supportive in that respect.
That's great. Yeah, the social emotional piece of it is so big. It's one of the, I've learned since being diagnosed, the 5 pillars of brain health, you know, nutrition, sleep, exercise, but the emotional component of support is just vital. So I'm glad you found that. I haven't quite found that yet. I'm gonna look for my no whiners support group. I'm not here for the whining either. Maybe the other kind of whining, but that's a support group I would lead happily. Ken, you said you were in a bunch of different exercise programs and gyms specifically for Parkinson's, which I'm fascinated by and want to learn more about. But is there one exercise that really has done more for your symptoms than others?
Well, the 2 classes that I'm in are totally opposite. One I call, it's more stretching and whatnot, yoga on steroids. When I leave that class, I feel like a pretzel, but it's good. Just learning how to get up off the floor is something that they go over. So these are things that are, you face them every day, climbing stairs, getting off the chair without using the hand, you know, just exercising. And the other class is more weightlifting. So I'm thinking I'm probably got the best of both worlds. Just running back, one thing I wanted to say is when I came to that point, deciding what to do, when I found out I was diagnosed, I thought to myself, well, I got 2 choices. I can go sit in the corner and cry, woe to me, or I could become active, be an advocate, and that's where I'm at. And I've been working with the Michael J. Fox Foundation, working with legislators. They're looking for people that could just tell their story, as well as other groups that I've extended to. Not to steal your thunder, but knowledge is power. And I live by that principle.
Yeah, well, on that note, I'm gonna put in a plug for those of you who haven't already done so or don't know about it, but the National Plan to End Parkinson's is currently in the hands of the Senate. As many of you know or may not know, we are waiting for it to be called up for a vote. So if you haven't contacted your senator, do so, hopefully soon. I have reached out to both of the Virginia state senators and begged them to put it forward for a vote. So it's really important right now. And I too have been working with the Michael J. Fox Foundation, and they have high hopes that we'll get it passed. So when you go home today, you can go on the Michael J. Fox website. They have a form you can fill out. It literally takes 2 minutes and your voice will be heard. So I was gonna do that at the end, but you beat me to it, Ken. That's great. Rory, you are the lone and heroic caregiver, care partner up here with us today. Rory mentioned he wrote a book about what happens when you first are diagnosed. Rory, what would you tell people? What is the first thing they should know or do after they receive a diagnosis like this? If you had to pick one. Put you on the spot.
I'm not sure about the first thing. I think that you can still live a rewarding life, a life full of happiness. I think it's important to learn all you can about what you're dealing with, because since it's progressive, it's going to change over time. And I think it's important, if you have support, you need it. Eventually you'll need it. And support is incredibly important to let them know what your situation is, because they don't understand it. Their caregiver is kind of like being drafted a lot of times. You weren't prepared for it, you didn't ask for it, and all of a sudden you're in this situation and you're trying to deal with it, and you don't really understand what you're dealing with. And sometimes the Parkinson's patient doesn't fully understand it either, because it's changing all the time. And so it affects the whole family. And so I think that if everybody understands, then they can work together to make things better. You can create schedules for medications. You can use timers. You can keep a diary of food and that you're eating and reactions and things so you can help your neurologist. There's all kinds of things that you can do. As far as the patient goes, the person with Parkinson's, exercise is probably the #1 thing. I used to tell people when I first meet them, when I was president of the organization, I'd say, don't sit down, don't just, as someone said here, they said, woe was me, and and yes, it's not a good diagnosis, but don't sit down, exercise, push the envelope, move, because the people who don't seem to progress faster. And those who fought it and worked with it and did the therapies and things like that, they moved forward. My wife had it for 23 years. We went through a lot of therapies. We went through a lot of changes. And so I've seen a lot of things, but I applaud all those people here have found ways to make their lives better through education and through trying new things to fight this. So don't just give up. And they are working on it more. So hopefully it'll come soon.
Okay. Joe, speaking of being drafted into a military like situation as a care partner, coming from your background, and do you find that having a regimented routine in your Parkinson's care makes a difference? Or as you were saying, you absorb a lot of knowledge. Has your routine and your care changed over the years as you've sort of learned more about this disease, or are you sticking to one?
Well, early on, I bought into the exercise, encouragement, and I believe it, and I still believe it. And so, as part of that, I did in my early research. I found out about that, and I came across a resource that I looked into and decided I was going to believe it. And there's a man in South Africa who's written a book, and he got Parkinson's diagnosis in '92. His name is John Pepper. And again, he lives in South Africa. And he's a worldwide Parkinson's layperson patient. And he's very, very respectable and credible and trusted by a lot of people, including myself. I just want to show you that this is the book that he wrote called Reverse Parkinson's. I ordered this off Amazon. I think it cost $20. And but I've emailed him, I've talked to him on the internet, but he's 86 years old roughly at this point. He's had it since 92. And he adopted the same strategy about the exercise and did it faithfully. And his Parkinson's just about became hard to even recognize and see. There's another word I want, whatever. But you know what I mean? People just didn't realize that he had Parkinson's. His doctors were apparently astounded by that. They questioned his original diagnosis and such as that. But he has a program that he's encouraged people to do, and that's what the basis of his book is about. And that is the hard exercise in his particular case, and this is what I did, is the power walking. And you know, you hear about people say they work out every day. If you were to me, you know, I'm a former athlete in high school and soldier, as I said, and I'm familiar with exercise on a pretty good basis. I have a good memory of what we've been through. We didn't do the same things every day on exercise, but I do hear a lot of Parkinson's experts say that they do it, or patients say they do it every single day. I'm not of that mind. I'm of an every other day kind of a guy, at least on the same muscle groups. Let's at least agree with that. But because your body needs to, you know, heal from its exercise. And so he believes in this power walking as fast as you possibly can. And of course, you have to build up that, and that's going to increase over time. But what I did early on after finding out about him and his strategy, my practice was to every 3 days a week, and it was generally Monday, Wednesday, Friday. And if I had something I had to do, I couldn't help it, then I had to skip that day and to get up the next day, and I had a weekend to catch up for my 3 days a week. And but in my case, I walked as fast as I could. I had a 2-mile track that I walked. I know exactly where 2 miles was, but I counted it with my watch. Actually, with my phone, there's a Run Keeper. There's an app on my phone, Run Keeper. And I found out about that. My preacher told me about it, and I liked it. And so I pushed the button when I start walking, and it starts keeping time exactly. It shows a route of where I walked. And I would look at that, and I had an alarm set on that program. At 30 minutes, the alarm would ring, and I would know that that's time for me to turn around. And I would get to 2 miles, and eventually I got to pass 2 miles in 30 minutes. And then I'd walk back and I usually ended up walking about 4.25, and I did this for exactly 1 hour. So that's over 4 miles an hour. That's pretty good if you've ever tried it. And I was doing that really faithfully for about 4 years. I'm almost 6 years into it now. And then unfortunately, I had something happen to my toe. They said arthritis in my big toe. My foot was killing me because when you take it long, fast strides like that, the back of your knuckles are really, you know, they're really overextending. I didn't realize that over time, this right foot mine, which is my bad side of Parkinson's, that toe started killing me. And so I went to the doctor and podiatrist, and I went down this path, but they led me down, and should have been a lawsuit, but there's no money in it for the lawyers. I talked to them about it. But I got where I couldn't really walk right. Then they put me on a boot, and that messed with my spine because I have a back problem as well. It's my nerve, and I couldn't walk for quite a while. Then when I got where I could walk, and I came back to my exercise program, something had happened to my gait, and I still don't know what's wrong with it. I just can't walk like I used to could. Not that I'm not in shape, but it's just very awkward and painful for me to walk. Now I've got this wobble in my neck. I don't know what caused that either, but I'm trying to get back to that. But I do believe in that, and I did do it you guys, my wife, she knows it was very faithful. I didn't miss any days, hardly ever. Anyway, that was my program, and I still believe in it. I'm hoping I can get back to it. But you know, you can't really measure where you'd be if you did or didn't do that. That's just not the way science works, because we don't have a control Joe and a patient Joe to compare. You know, you understand what I mean? So that's very difficult. People say, well, is it helping you? I don't know how to answer that kind of question, no matter what the therapy is that we're talking about. How do I know if it's helping me? I just trust that it is, and it's certainly not hurting me. And you do what you can, and this whole thing about Parkinson's, it's, as I told my wife coming over here, it's a maze. You know, you're like the rat going through the maze, and you want to get to the other side. You hope you can live a decent life for a decent amount of time, but you're going to run into some dead ends, just like I have with this situation I'm describing to you. That's a dead end, and I'm still running around trying to find the direction to find the path that leads out of that dead end, and I'm still working on that. I pray that I will find it, but you got to make sure that you don't give up on any of this stuff, because what good is that going to do you? So you're just trying to move forward and continue to look and study and try this, and try that until you find something that moves, works for you until you get to the next roadblock, and it's just that's just the way it is. I accept that.
Those lawyers, Joe. My husband's a lawyer. Put him on the spot. Well, we have about, I think, roughly 10 to 15 minutes left, so I wanted to open it up to questions for the panelists, if there are any. I don't know if anyone's brave soul questions. Yeah,
I think I did top well.
can you yell maybe?
How many of us in the room have multiple medical conditions?
How many in the room have multiple medical conditions? Yeah. Yeah, and I would argue that managing them all at the same time is a challenge in and of itself, so I hear you on that one. Yeah, yeah. Oh, nope, Susan was gonna.
I'm sorry. I just wanted to add something, was talking about exercise. These are the three things I think everybody with Parkinson's would get, and that is exercise and mindfulness. And mindfulness is like Dr. Wiliamsburg was talking about, your day is built on what today is. You don't worry about yesterday, you don't worry about tomorrow. You're gonna focus on today and live your life the best you can for the day. And it's really helped me turn me around 360 because I think I was reactive person and it changed I don't worry about things now like I used to, and I think I can, it calms me down when I feel stressed. And it also is important for your family to have you not be stressed because they're stressed, because you're stressed.
Yeah.
So I think that's the three things that are really good for dealing with Parkinson's disease.
Rory, that begs the question, how did you stay hopeful and positive as a care partner?
Oh, in the beginning, I was just frightened. I didn't know anything about Parkinson's and, there was a lot to deal with and I was trying to do the best I could. And continue to learn as we went, but I would like to say one of the things that helped was I realized how much help I could be. How many caregivers do we have in here? A lot, okay? You don't know will make it do, but you may not realize what a great impact you have on the person that you're helping. And sometimes it's not said, sometimes it's not apparent, but you're doing more than taking them to the doctor. You can be an advocate for them. You can look out for things, and as they progress, depending, everybody with Parkinson's is different, but as they progress, they may not be able to fend for themselves as much. And the medical community can be kind of like drive-by medicine sometimes, where they come in, but they give you a 5-minute talk and say, okay, see you next month, or see you in 6 months. And if you don't say, wait a minute, we've got some questions, then you can't discuss alternatives. You can't discuss different medications. You can't discuss therapies. You can't, they'll talk with you if you stop them, but sometimes you have to be an advocate for a person you're working with. And you can make a tremendous, and are making, but you can make a tremendous difference in that person's life. Don't underestimate your value, because you're really doing an amazing thing and helping someone else. And just keep learning about the disease you're dealing with, because it's always changing. It's always a moving target. And you can do a lot of good.
And care partners and caregivers need to take care of themselves too, because you all are stressed and your health is equally important. So I know it's an all out exhausting enterprise in many, many ways, so.
I learned that the hard
Yeah, definitely. Any other questions? Yeah, oh, lots, okay.
Not really a question. I'm a statement of the story that I enjoy telling. When Jonathan was diagnosed in 2017, we were blessed with a very wonderful doctor. And I'll never forget this as long as I live. Try not to be emotional. We were in the examining room and Jonathan was sitting on the bed and I was sitting in a chair and he came in and sat in front of me. And he looked at JP and he said, "You are not gonna talk. You are gonna sit and you're gonna listen. And I'm gonna ask your wife all the questions." And I did, and I think that's so important because we see what they don't see. And that's how we have gotten through the last 7, 8 years. You know, I'll say to him, "What's that face for? You know, what is that?" You know, "What? Oh, why did I do that?" You know, but he was very much a blessing. And he left the room, came back in and said, "Jonathan, I knew the minute I walked in this room that you had Parkinson's." But that's how he was diagnosed, and I'm very blessed.
Yeah, I will say that having a doctor that you can relate to that really spends the time, and doctors are obviously unsung heroes. They're under so much pressure and stress and have so many patients. Mine in Baltimore has been truly exceptional. It's changed my entire course of care. And I know that that's rare and hard to find. So I agree, doctors can make a huge, huge difference. There was another, yeah.
I don't think for sure. I just wanted to ask, how do you remember to take your meds?
Good question.
Okay, I can tell you, I can speak with it out. The medication, she's asked me, how do I remember to take my medications? Well, I use the pill box for sure. I've got 2. I have one upstairs and I have one downstairs. So the one downstairs is the one I take with my breakfast, obviously, at the dinner table. And then the one upstairs is the one by the sink, by the toilet, the bathroom. I get up in the morning, I take them. And my wife reminds me all the time that I should make better use of the alarm on my cell phone, which, you know, it's true. That is an excellent tool. And so between those 2 things, I don't have a problem. And of course, she verifies that I've taken it, if she's with me, because she works. And so she'll say, "You taking the pills?" And usually I say, "Yeah," but occasionally I go, "Oh, yeah, no, it is." Thanks. One time I moved, my child left home or something not that long ago, and I moved to his old seat at the table, and my pill box was on the other side of the table where I was sitting. Not that long ago, it's about a month ago. I went, I think, 4 days forgetting to take my pills in the morning. It was not so much about Parkinson. Well, one of them was I take 2 Parkinson's medicines. One of them was the Parkinson's medicine. I didn't take it. It was I guess the lesser of the 2. I didn't take it for 4 days. My vitamins, I didn't have them. My blood thinner medicine, I didn't have them. Then one day I realized, man, I just realized I hadn't been taking it. That was breakfast time. She wasn't there. But
There's actually a great app, if you all haven't seen it yet. It's called My Moves Matter. Not affiliated with them, but just found it. It's specific to Parkinson's and it will track your pills. You put in exactly when you have to take them. It gives you a reminder and then you have to check the box to show that you've taken them so that you don't forget.
I wear a watch.
Oh, Susan's got an Apple Watch.
Yeah, I've got I don't know what they. Yeah. What? Apple Watch. I set the alarms and it puts the medication in and like my 2 o'clock just went off. So I know I need to take
My problem is I set the alarm and then dismiss it.
Yeah.
Never gonna take the medicine. I think.
Talking about times, if you recently heard a phone ringing that way, that was my 2 o'clock. Wife digging around in the pocket to find my phone. So everything, the thing too is I take one at 2 a.m. When I have to get up anyways. And there's many times where I just sleep right through the alarm, even though it's right here, right next to my head. because I am out. I actually sleep better than I used to sleep now that I have Parkinson's. Don't ask me why, but it's true.
I think that makes you a unicorn, Kat, because no one else I know that has this disease sleeps very well. Yeah.
When we had introductions, I meant to say something I forgot, and it was brought to my attention right this morning when I first got here. That we have students in the room that are studying neurology, and I know they're over here, and there's maybe any of y'all raise your hands so we can see who y'all are, your students. I want to say that I was very touched to know that they would be here, or to hear that they were here. I didn't know that they'd be here, and I'm thankful for people like that to see that there's a need with us to help us. And that they're choosing to make apparently their life work to assist Parkinson's patients. And I hope that Parkinson's patients as a group are the kind of people, and I think we are, that will show appreciation and be responsive and respectful and be interested in the things that they're going to try to teach us in the future. And I'm just thankful that y'all are interested in us. Thank you.
Thank you. I think we have time for one more question. Anyone else have one? All the way.
Question about the things you go through with your body, like, it started with my left leg. Every day I have pain in my leg, so I try to walk it out, kind of stretches, my stretches. But then, like months later, it switched over to my upper leg. It's never both of them at the same time. Did anybody else have that problem?
Yeah, I think pain is is definitely one of the things. I personally am not a doctor, so I won't answer your medically speaking, but pain is one of the symptoms that I deal with every single day. My tremor is very well controlled with meds, the pain not so much. So I find myself having to stretch constantly. It doesn't really solve the problem. So if you find out, shoot me an email, let me know. Yeah. Well, unfortunately, I think we're getting close to the end of time. I will give the panel just one last word each, maybe to say a final statement.
I guess I've said enough. I'm just thankful to be here. I've been to 3 different co-op conferences, I guess, between here and the last one was at Riverside Hospital, and before that it was somewhere in Williamsburg at an auditorium. But I think this is the best one I've liked the most, and I enjoy it. I appreciate y'all doing it, putting it on.
Just want to thank you guys for taking time out of your days to be here, to hear our stories, to hear from the physicians about what Parkinson's is all about.
I want to thank you also for being here, and all you parties, keep positive attitude and exercise. And it's not the end of your world. You're just going to change your world. You're on a new adventure.
I'd like to also thank you all for listening, and I think that trying to keep a positive attitude is one of the most important things you can do, and possibly adding a gratitude list each morning is a great way to start the day. If you list 3 things, 5 things that you're grateful for every day, it's very hard to be depressed and grateful at the same time. So, I wish you all the best, and good luck to you. Thank you for having me.
And I'll just say thank you to the APDA staff, Naomi and the team, and thank you all for having me. Thank you for making my first panel discussion painless. And thank you to the panelists too. So.
So we're going to switch gears. Our next breakout session will begin momentarily. Our next breakout session for here will be on occupational therapy and home modifications in the home. And in the other breakout session, we will have a discussion on Parkinson's disease and nutrition. So in here, we will have discussion on home modifications and Parkinson's disease. And the next breakout session down the hall will be on nutrition and Parkinson's. So if you have any questions, please feel free to see our volunteers with the yellow lanyards. They'll point you in the right direction. Wait. Oh.
I know, we're in Arlington, Virginia. I just started a Parkinson climbing class. I'm trying them all. Yeah, I'm trying them all. Yeah. I'll get your information. Thanks. Oh, thank you. Yeah. Well, thank you. I know. Thank you for my help and selection. Yeah, we're gonna head home and get safe. Thank you so much.
We're going to get started in another minute or two. So around 2:17, we're going to go ahead and get started with Jessica Sheffield from Riverside Occupational Therapy.
Thank you for
And the final one was for the care plan. Did you bring some? All right, we're going to go ahead and get started. It is now my pleasure to introduce Jessica Sheffield from Riverside Occupational Therapy. Jessica received her master's degree in occupational therapy from Eastern Kentucky's University in Richmond, Kentucky. Jessica joined the Riverside team in 2013 and currently works at the Riverside Shoreview Outpatient in Newport News as the primary occupational therapist and clinical coordinator. Jessica is a certified stroke rehabilitation specialist who specializes in neurorehabilitation. She has been an LSBT BIG certified since 2014 and has worked with many people with Parkinson's disease over the years. With a holistic perspective, she strives to help her patients to be as independent as possible in order to maximize their movement and quality of life. Please welcome Jessica. I also want to point out that we do have surveys on our tables. Please feel free to write down any suggestions, any feedback, anything about the speaker that you've enjoyed or would like to see in the future, as we plan for more things next year. So just a mental note that we have surveys on the table for you guys. Thank you so much.
Much time. All right, okay, I can do it. Is it on? Yes. Okay.
And then you can figure out the next slides.
Okay, all right. Can you guys hear me okay?
Yeah.
Okay, so living well with Parkinson's. Now we're going to talk about home modifications, and so we'll get started because we got about 30 minutes. A lot of questions at the end, so I'm going to try to get to that. I am originally from Kentucky. Anyone from Kentucky or lived in Kentucky? I think I saw someone with a big UK on there. Nope. So I'm originally from Kentucky. I joined Riverside, and I currently work at Shorty Outpatient. So I'd like to talk about what is occupational therapy, because we know physical therapy. A lot of responses that I'm not looking for a job, or I've been retired, or so I want to kind of go into that first. Occupational therapy. What I love about OT is we're really holistic. We're kind of the middle between the speech therapy and the physical therapy. So we're like the bridge between the three disciplines, right? So our focus is being independent for as long as possible. We really want you to keep moving and keep doing as much as you can, because that's what's going to help maintain your balance, maintain your strength, maintain your endurance. And so from an OT's perspective, what do you need to do? What do you need to use when you're doing things? Is your arms. So we're looking at range of motion, we're looking at strength, we're looking at your fine motor, your gross motor, we're looking at your mobility functionally, right? Within the home, going to the bathroom, going to the kitchen, living life. So we're experts at task analysis. So if there are things that you're not able to do or it's harder to do, we can show you modifications. We can break down those tasks because we want you to be independent for as long as possible. So that's what we're going to talk about today. So falls, I want to talk about this first. According to National Institute of Health, about 73% of the falls occur within the home. And above that 73%, 80% of them occur in the bathroom. And what's interesting, according to CDC, 1 out of 5 falls usually lead to serious injuries, broken bones. So that is why it's so important to really be mindful of how our home is set up and how we can modify. Of course, pro-therapy, so also therapy, but we'll talk about that later. Okay, so this is the basic standard one, safe home environment. Remove that clutter. Okay, that's the first step you can easily do in your home, especially if you live in an older home or if you have been there for many years. It's easy to start accumulating. Antique furniture, things kind of get crowded within the room, so you have to get creative navigating. What I will say to that is that we need to work on cluttering, cleaning that up to get a wide path, walking path, so we can allow for walkers to be used, we can allow for canes to be used, and it makes it easier for Parkinson's, for that patient to be able to walk through. Freezing hesitation, when that happens, the clutter is it's going to be an issue. So sturdy chairs, you'd be surprised some of the folks that told me they were sitting in office chairs or things like that. You want a chair that's nice and supportive for you, with sturdy arms, height. Sometimes you can get creative. So that is a conversation you can have with a therapist. There are some modifications that can be done to your current setup. So that's the biggest thing. Okay, so pets, I'm a big fan of pets. I have 2 dogs and a cat. So I definitely encourage you to still have your pets. Sometimes people are like, oh, you need to get rid of your pets because they'll get in the way, but you can still manage. The biggest thing is starting to teach your pets, make sure they're not jumping up on you or jumping up on others. That really makes a big deal. You can even put a collar on them with a bell so that you can hear them coming into the room. That's something that can be done. Baby gates, you can certainly set them up, blocking the pet going into the room that you are in. So there's lots of options out there. The biggest thing is, being mindful of the pets. If they're in your way, sometimes people use their cane to kind of, shoo the pet out of the way, or so that's something you want to think about. Okay, lighting throughout the house is so important. especially for nighttime, especially in areas there's not, windows. It's a pretty dark area. For those with Parkinson's, it's very, when you don't have good lighting, it affects your vision, and then of course it affects your walking because you're not confident. So it's a really important thing. So there is all kinds of great new technology out there. Night lights, where you can plug it into the wall. There are ones that have that auto dusk to dawn. There's motion sensor type of night lights or things that you could put in your hallway so it detects movement. It's gonna light up the space, which is really, really nice. You can find this stuff on Amazon, online, or even in the stores. Stairs. Stairs is a big issue, and especially in homes that I do find that really frustrating around here is that a lot of the 2-story homes, there are no bedrooms on the first floor. And so that makes it difficult. So an easy thing that can happen is a visual cueing. Putting tape on the bottom of the step, at the top of the step. Because a lot of times folks, when they have those falls, they will say, I thought I was on the bottom step when I took that step. But really, they still had 2-3 more steps to go. So highlighting that visual cue is really important. So you can put on the bottom, at the top, as the example provided, you can even highlight all the steps, especially at the outside ones going into the house. Lighting is also important, especially if we're going up the stairs, you don't have a well-lit stairs. So there are options there where you can get battery power nightlight type things and stick it onto the wall. Or even outside, there's solar panel type of night lighting that you can install. Very inexpensive, especially if you look online. Bathrooms. So this is the #1 place where people tend to fall. And the reason for it is because it's a smaller, tighter space. So it makes it harder to navigate in there with your walker, makes it harder to navigate in there with your cane. Biggest thing here, easiest thing you could do is remove those rugs that you find in front of your sink, front of the toilet, front of the shower. Those, decorative type of rugs need to go. And I always tell people, especially older homes, toilets are lower, or if you're having a harder time getting up from the toilet, an easy fix is getting a 3-in-1 bedside commode. What I like about those is that you can put it over your toilet. You can use that, you can adjust the height and there's arms on it. But then if you are one that you are having to go to the bathroom throughout the night, and we know that walking into the bathroom at night has caused some falls, if you're really having difficulty, or you're having to wake up your caregiver to help you walk into the bathroom safely, the 3-in-1 commode can be placed right next to the bed, so that you can meet those toilet needs throughout the night. It's a lot safer. So that is kind of a nice, good investment. I will say this about grab bars. If you are finding yourself holding on to that towel rack, that towel bar in your bathroom, or holding on to that soap dish in the tub shower, what I will tell you is that those are not grab bars. It just takes that one bad moment when you're getting up, you thought you were getting up correctly, but then you start losing your balance, you start grabbing onto that towel rack, and you both go down. So in this picture, I showed the grab bars. Doesn't mean you need all of those. It just shows that there are lots of variety of vertical and horizontal grab bars that you can get. Handyman, some of the improvement stores offer those services where they install the grab bars. Do not go for those suction cup grab bars. Those are not, a good example is I have a shower rack in my tub shower that holds my shampoo, my soap. Those suction cups from time to time will pop off. And so those suction cup grab bars that you find at the store, it just takes that one time that you're trying to rely on it, and both you go. So the biggest thing is we want to keep you moving, keep you independent, right? So we want to eliminate those falls as much as we can. So those grab bars are really nice. Some folks will put grab bars down their hallway, especially because, again, the lighting situation, they're having a harder time. They'll put grab bars installed throughout their home. So whatever meets your needs. And again, in the bathroom, we want to think about appropriate lighting, those night lights, those kind of things. Kitchen, okay. I want you to keep on cooking, preparing your own meals. And so if you find yourself reaching for your certain things that are kind of lower bottom of the cabinet, or you have to step on a stool to reach up to grab something. Reorganize your kitchen and make it work for you. Things that you use often should be within reach, so we can keep you independent. A lot of time people are a little nervous trying to cook it with a hot oven over the stove, especially if you live alone or you are alone during the day. There's all kinds of new gadgets out there: air fryer, convection toaster oven, crock pot. You can certainly use those. So there are some modifications that could happen so that you can continue to keep cooking. There are adaptive cutting boards out there. I know cutting can be, especially with the tremors. There, as the picture, I used to have them, but the picture you can see they have like a knife that's anchored, so it's stable. You throw a potato on the spike, and you can use that knife to slice through the potato. So that is an option. I brought this one. This is just a regular cutting board, a small one. Same thing, the spikes are there so that you can put a vegetable or fruit, and it holds it in place as you try to cut. So that's really, really nice. Electric jar openers, that's a new thing, and it actually does work. Because some of those gadgets may not work, but these actually do. What's nice is, of course, opening jars can be very tricky. And I will be honest with you, it's not you, it's the jar. Because I struggle with opening jars. And so something like that, you can put the jar opener right on top of the jar, press the button, and the arms come in to the jar, it puts it open, and then it releases it, and then you just got yourself a new jar opened. Meals. So let's talk about this. If any of y'all have ever been to see an OT and you have tremors, a lot of times a typical OT, a traditional OT, will put some ankle weights on your wrist, maybe like 1.5 pounds, 2 pounds, sometimes it can go up to 4 pounds. So they put these heavy weights on the wrist and then give you a heavy weighted utensil to help you to try to work through the tremors to still feed yourself. And what's interesting, there's actually not research to support that. In fact, research actually supports lightweight utensils will actually encourage, support more smooth movement pattern to feed yourself versus weighted. And then there are other research articles that, it really is patient preference. And so that's why I support. Some patients, maybe the weight of the ankle weights on the wrist does help. Other patients, no, it's too heavy. So really it's a trial and error. And so I wanted to show you there's several different options. I would encourage maybe seeking out an outpatient OT, or maybe if you are in home health OT, and they would certainly help with this process. So there are weighted regular utensils, you can see in the middle with the silver. Those are weighted, but they look like regular utensils. Then you got the classic built up weighted utensil. Then you got the regular weight, just built up utensil. Then you got the swivel kind of utensil. So when you're having the tremors, the idea is that some of the food will stay on the spoon or the fork. So you got some of that. Then you got the swivel, where it's a bendable, like the bendable spoon fork, where, so I'm left-handed, but you can bend it. So that way you're not having to, do all this, you just scoop and bring to your mouth. So that's an option. And then for some of you probably have seen on social media or online, the Parkinson spoon fork, and that is with the kind of the robotic, where you turn it on and it's using technology. So as you're shaking, the idea is that it's going to help counterbalance that so that you can bring it to your mouth. So a lot of times people look at this and say, "Ooh, this is great," but to be honest with you, this was donated to me by a patient who it didn't really work for him. But so there are lots of different options when it comes to feeding. And I would tell you, just actually going to see OT for that, and they can certainly practice, or you can certainly purchase some of these things online if you wanted to try it out. So these are some options out there. So according to research, lightweight, just regular utensils are helpful, but I've had patients over the years, it really is a personal preference, it's trial and error practicing. When it comes to knives, so there's a couple of options. The rocker knife, okay? So we got that. And there's what I call the rocking tea knife. Of course, mine's more like it looks like a pizza cutter. So of course, if you have arthritis, the one, the picture in the middle, there are a lot of resources out there. The idea when it comes to cutting your food is that we are trained to hold the fork with one hand and then saw, right? We're sawing the piece of meat. So of course, we learned this morning that, anyway, so the idea is we're switching it to rocking. So when we rock, we're going to have a little bit more power, more force to really cut through something. And it does work because I have 2 little kids. So when I'm holding, my baby who's a mama's boy, I'm holding him, I'm using the rocking method. So I can tell you right now, it does work. So rocking will really help to cut that food. Because again, we're encouraging independence. The more independent you are, the more you're moving, the more you're motivated. So we want to keep that going. When it comes to food, a lot of times people will complain that they just can't quite get the food in their mouth. It shakes across the plate and it's off the plate. So there's lots of different options. This is the plate guard. What's nice about this, it looks small, but you can actually, it will fit a regular dinner size plate. So you can put this, so I'm left-handed, so if I'm feeding myself, I'll put this on the right side of the plate. And I could go, if I'm trying to stab a green bean, bring it up to the wall, stab it, and there you go. So that's an option. Scoop dish, scoop plate. To me, it's a little backwards, but the scoop plate is more like a bowl with one side at the wall. And of course, this is a scoop dish. As you can see, it's got the wall on one side, same thing. But on the opposite side of your dominant hand, and you got that as a barrier to be able to continue to feed yourself. For me, I always like to utilize people's resources because again, all of this costs money. Another alternative is using a pie dish, a narrow, not a deep pie dish, a narrow pie dish. You got your wall, that could certainly help. Soup, we don't really need to use soup in a bowl with a spoon. You can put it in a cup and drink. So there are lots of different options there. Non-skid placemat, put under the plate. A lot of times people will say when they're feeding, the plate moves around, especially with tremors. So you're chasing that plate, so it's not a fun experience. So I would say like the liner that you put on your, like the shelf liner, you can put that under your plate. That will hold the plate in place. Or if you have placemats, those are good options. That blue thing under in the corner is called Dicem, D-Y-C-E-M. Dicem is an amazing blue sticky stuff. I don't even know what's made of, but so we use this a lot in therapy. You can actually use it to help open jars for yourself. Online, you can certainly find, they have all kinds of different products out there, but that is another option. I like to highlight walking. Okay? Again, I'm an OT, I'm a bridge between speech and PT. So when we walk, we're walking with purpose, right? We walk to the bath, we walk to the kitchen, we walk everywhere, right? To do things we want and need to do. We get a lot of time, people are very resistant to using assisted device. And I'm gonna just give an example, a person who he falls maybe 3 or 4 times a week. And he's had, 20 falls in the last month, and it's not using anything. And so when you bring up, why don't you use XYZ? And they're like, I want to be independent. I don't want to have to do that. I don't want, but honestly, using a walker or a cane is going to help reduce those falls. So then you're more likely to walk more because you're not falling. Because when you have that many falls and you're not using anything, you're more likely to be sedentary, more be sitting and only getting up when you need to do something. So we want to change that mindset, not needing, but needing and want. So there's lots of different devices, cane, quad cane, you got your traditional rolling walker, you got your rollator. The difference between the rollator and the U-step walker is that the rollator, a lot of times, especially if you got freezing and hesitation, and you'll, a lot of times those rollators get out too far, and then you're freezing, you're hesitating, and so then that could be problematic. The U-step walker is nice because it prevents that from happening. Has those built-in brakes. In fact, you can even get a laser attachment for that visual cueing, that external cueing that's really helpful for freezing and hesitation. So what I would recommend is that if you're one of those people or you have a loved one that is walking, having multiple falls a day or multiple falls every month, they need to get into therapy. And I'm a big fan of they should get OT, PT, and speech. Those are the tune-ups that these folks, with anytime you get a Parkinson diagnosis, you get on the medicine and you start establishing a relationship with your therapist. Because these are the folks that are going to help guide you to be as independent as long as possible. Self-care, I'm just going to highlight on this a little bit. There's lots of different stuff out there. That's why I think, establishing that relationship with your OT can certainly get you through these. Buttoning can be very challenging. And I love this because a button hook is $5 to $6 online. And when I show someone they're struggling and they just can't, so they have to have their spouse or caregiver to button their shirts, especially the gentleman that I've worked with in the past. I introduced the button hook, and it's, got like the handle of this, and they're going through the hole, fish the button, and they pull it out. The smile and the shock that I see on these people's faces, I'm like, I know, $5. And then there you go, you're able to button your own shirts again. So that's a great tool. If you've had hip surgery, knee surgery, well, hip surgery and back surgery, you'll probably recognize the kit, the sake, there's reacher, there's dressing stick, there are all kinds of stuff out there. What I would tell you is that if you can still get dressed without using any of this, then keep doing that. But the more you keep doing that, that's going to keep challenging you. But if you get to the point that someone else has to help you get dressed, then that's when you want to introduce some of these things. The biggest thing I want to highlight here is that I get a lot of folks that are still getting dressed standing up. And these are the folks that maybe they're falling multiple times a day or multiple times a month. My thing is, there is no right or wrong in how you get yourself dressed. However you do it, as long as you're safe as possible. So the people who are, all right, I'm gonna lean up against the corner of my door or the corner of the wall, I'm gonna work on taking a few seconds to get my balance and try to quickly put on the pants, and they're losing their balance and they're taking 45 minutes just to get a pair of pants on. How exhausting. Sit down. Sitting down to do these things, you're going to reduce the time, you're going to save the energy, and it's going to eliminate the falls. So, and again, therapy can certainly navigate you with this. I do want to highlight smart technology. And a lot of us know like the smart voice activating, like the Alexa, the Echo, but I want to make sure you guys know that you can also have the smart technology using your phone or tablet, because as we know with Parkinson's, our voice gets a little bit softer. It can be hard to enunciate some of those words, and it can be frustrating, but you can utilize the smart technology using this touch of the phone. So there's smart outlets that you can buy, so you can plug in your lamp, you can plug in whatever, and then use your phone to turn that lamp on. You can use the technology for the thermostat, the security cameras. Maybe you want to see someone's ringing the doorbell and you're having a really bad movement, the medicine's worn off, and you know that trying to walk through that door is going to be a little sketchy. You can just pull up your phone, see who it is. Oh, it's someone you don't know, you don't have to worry about. You can adjust the lights. In fact, I saw you can get a robot mop now, which is something that incredible. So there's lots of smart technology. And so taking advantage of that can certainly help, especially if you progress further along, getting smarter, not harder, right? Technology for safety. Now smartwatches have come out. I'm just highlighting Apple, Samsung, Fitbit. So if you are able to detect if you had fall, and then pop up with the option, did I fall and I need help? Request pay. And I'm big certified. I've had patients come and see me, and it's hilarious because their Apple Watch, they're doing big movement, and it will detect thinking that they're falling. So and it does work. So we have to take the watch off and just put it down while they're doing their exercise. But just know that there's lots of options. Keeping your cell phone on you. You can get a necklace with putting your phone in, so you have your phone with you at all time. I think it is a problem. We don't want you to have that fall and then stay on the floor for long periods of time. So, so there's some great technology out there. Okay, I really want to make sure that it's so important that
We're not just thinking physical therapy, but we're also thinking occupational therapy and speech therapy. All three disciplines working together, research supports when you have a multidisciplinary team, your outcomes may be better because this is all three therapists, it's your neurologist, it's your primary care doctor, it's everybody working together to help maximize your quality of life, which encouraging movement, being as independent as long as possible. So with that being said, a lot of times people think, I go and see PT, that's a one and done. If they tune up, you're going to expect it to go back for tune-ups. Maybe some people it's 3 months, maybe it's every 6 months, maybe it's once a year. Maybe it's every other year. It depends on your needs, but just being mindful that therapy is going to be very, very important. And through therapy, it may not be outpatient therapy. Maybe you have a loved one that has Parkinson that's in a skilled nursing facility or assisted living facility or independent living. There's several different therapy type of options. Or if you know someone that's homebound that cannot get out of home, physically cannot get out of home, they can get home health therapy. So I do want to highlight that it's not just outpatient, there's home health option. There's a PT that's currently works in a skilled nursing facility up here in Williamsburg, and she has got LPT trained. She's trying to start Parkinson's support group. So there's lots of options. I think a lot of it just kind of asking about it. And the therapy, and I just kind of highlight on some of the modifications, but if you have an issue, have a problem with certain tasks and you can't do it or want to help you, that's where the therapist can come in to help problem solve because we want to keep you independent. Okay, so any questions?
I have a question, just a comment, the question. So like grab bars, and you mentioned they're handyman, and it makes me nervous getting somebody in to drill through tiles and getting it in the right place. Do you guys have like a list of people who do things like grab bar installs?
So I think, so at my outpatient, we get this question a lot. So if I hear from word of my mouth, you know, oh, so there's not really a list, but I have a few, so I can certainly give you my card, you know. Unfortunately, there's not, I don't really have a list, but I have picked up things over time. I've heard about, oh, this company does, oh, let me get that information because I'm all about using resources. But yeah, I do understand that. And I know that, but I can certainly provide that for you.
Thank you.
Yeah.
The other thing, just a comment, this is all great stuff you showed for in the home. I was just gonna say, I have a friend who's much more advanced in Parkinson's than I am. And he had, for going out to eat, he had cards made up that he'd hand to the waiter discreetly, asking them to cut up the food before they ever bring it to the table. So the wife isn't reaching across the table to cut it.
Oh, that's a great idea. Yeah, I think that's actually a fantastic idea. So thank you for sharing that. And so the patients I see, you know, I teach them the rocking method, and it does work. And so, because a lot of times that's what people, they stop going out to eat because they don't want to have people staring at them. They don't want someone else cutting their own food, or they'll change. They won't eat their favorite dish. They'll just order a salad or something so they don't have to cut. So there are, certainly that's a great suggestion, or go into therapy and practice these things so you can build up that confidence. Because for us, we want you to keep going out in the community, right? Because that's social, mental health, and movement, right? So yeah.
So great ideas. We had a couple. Do you have any samples with you of any of these products?
Just say that again.
Do you have any samples with you of any of the products? So for instance, the dresser or the dressing item or the things to help with that. Do you have any examples with you or just the pictures?
So yeah, just the pictures and of course the stuff I have here. Because I was thinking, gosh, if I could just throw all this stuff in my car and bring it all up here, then I can't. So that's where I really push back for you to talk with your neurologist or your primary care doctor to say, I need to go. The key is I need to go see a neurotherapist. Generally, you know, if you're going to, you know, orthopedic type of outpatients, they may not have this kind of stuff, but if you go to a neuro outpatient, that's probably gonna be the key word, is that a neuro outpatient, neurotherapist will have some of these things that you can practice. But yeah, I don't have the other stuff, but I wish I could have brought everything, but.
Can you tell me if there's some way that you know? Can you tell me some way to find a doctor, a general doctor, that would be familiar with Parkinson?
Trying to find a way. That's a great question. So of course, you know, I work at Riverside and I'm gonna promote Riverside. But you know, I would say if you want a doctor that is familiar with Parkinson, really your neurologist. Okay, Dr. John is a perfect example here. We actually have a couple of neurologists, and I know all the healthcare systems they have neurologists that are really more Parkinson support and Parkinson related. When it comes to general providers, that's what the other primary. They're looking at you holistically. They're looking at your blood pressure, your diabetes, and your cholesterol and that kind of thing. But when it comes to specializing, and Dr. John probably can give more information on that, but I always say, like, if you have a heart issue, you would go see a cardiologist. You have eye issues, you would see an ophthalmologist or optometrist. A neurologist is that one that's really going to help guide with the Parkinson's.
So I'm a neurologist, and I think that comment was probably more of a comment on, you know, medical education in general, I guess. And I don't blame primary care doctors if they don't know these diseases, because number one, Parkinson's disease, you know, it was sort of put together as a syndrome back in 1817. So we are coming up to like 250th anniversary of this disease, right? Actually beyond that now. So over the last 200 years or so, we have had so much of advances. We've known so much. We have, as you can imagine, we're looking into, you know, how a tiny chemical from 1950s is affecting your brain, right? So much to learn for all these doctors, so much that we have given it to people like me or Dr. Butler or somebody else, right? So we are specializing so much that we have doctors for the left nostril and the right nostril and all that. So I would recommend Parkinson's disease should be treated, if possible, by a Parkinson's disease specialist who has extra training on top of their neurology training, who has seen Parkinson's disease patients in as much of flavors as they can come in, right? If not, then go to a neurologist who is training for that. And I think at the moment we have a good program in the country where neurologists are being trained as Parkinson's specialists and sent out there to the world. We are trying to educate the primary care doctors so they know what medicines interact with their medicines or what problems come in with hypertension or low blood pressure, things like that. But I know that is actually hard for them to learn because they have to treat diabetes, they have to treat, you know, toenail fungus to everything, and also finish up paperwork that people are putting on their tables, to everything from prior authorization for headache medicine to, you know, nursing home papers for grandma, right? So you can imagine that is a huge work for a primary care doctor who has to see 30 patients a day. I can sit here and talk about Parkinson's disease all day because I see 12 patients a day, remember, and I spend 1 hour with the new patient and about 30 minutes or so for a follow-up patient. So I have that luxury, I get paid to do that. Primary care doctors don't. They have 15 minutes to see you for 5 problems and they have no time to actually go and write these notes, right? So that is why they don't seem to know everything about Parkinson's disease. Just, you know, forgive them, they are overburdened. In this country, I don't think we pay as much for primary care doctors as much they do for neurologists. So yeah, sorry, that's a ramble, but I think that addresses the question.
All right, about one last question, and then we're gonna go ahead and swap for our last breakout sessions.
I'm a caregiver. At what point
the person with Parkinson needs to be referred for adjustment of driving and to apply for a disability permit, or for that matter, re-evaluation for driving skills. Is there any particular resource to determine specifically for Parkinson individuals?
Okay, so the question is that the
Driving, evaluating people's driving skills.
All right, so that's a great question. So, and actually, the right person to ask. So, when it comes to driving, so it's very much a gray area, okay? So it's not black and white. So I would say the biggest thing is using your judgment. So first off, for some people may not be using their judgment, but could be a conversation with your doctors, right? You know, because the biggest thing, this is just because of what I do, because I get a lot of people coming and asking me about driving. I do an off-road driving assessment. I'm the only one in Riverside that does this, so I get all of those folks. And so the biggest thing I always like to tell people is that we know that you can drive. Because I've had folks come in like, I've been driving for 7 years, I know how to drive, and you know, the biggest thing that we're in the times of you get in that car accident and you come out of that vehicle and they see anything, even if it's their fault, they're going to be quick to try to sue you. They're going to be quick to say it's your fault. And so that's what we want to think about. We want to make sure we're safe so that that child comes across the street or that pet or whatever, you're able to have that quick reaction time to go from the brake to the gas pedal, you know, and vice versa, whatever, right? And so when it comes to the driving, that is very much a gray area. I would say if your gut's telling you, I'm not so sure, especially with Parkinson's, we know we have good moments and bad moments. We have good days, average and bad days. And that's how I like to have my patient come in. It's like, are you having a good day or having an average or bad day? Because that gives me an idea where we're at. So if you're having a bad day, that's probably not the day to be hopping in the car and driving on the interstate during rush hour time. And so if your gut's telling you, I'm not so sure, then really listen to that gut. And I know that driving is so important. We kind of associate driving with independence. But it just takes that one accident for you to get into serious harm or harming someone else. You know, there are lots, so there's certified driving specialists. There are several in the area. I actually have a list of that. I do an off-road driving assessment, so that is needed for hesitating with the reaction time and that kind of thing. I could certainly, you know, get an order for the doctor. I can certainly run you through that. But if you're questioning your ability to drive, then that's maybe a conversation to have with your family and your friends, because you know, sometimes they're the ones that are going to be more honest, like, I was holding on, you know, you didn't quickly hit that brake fast enough for my liking. And, you know, so it's very much a gray area. Yeah.
We had his doctor actually send a note to the DMV and they demanded he come in for a brief test.
Correct.
Otherwise,
Correct. So doctors can report to the DMV. Actually, I think anyone can probably report to the DMV if there are questions with that. Yeah. And so the DMV will require you to come in to do a written and a driving assessment. So if you fail that, and then they take your license away. So yeah, it's very much a gray area for sure.
All right, well, thank you so much, Jessica, for that presentation. We're going to do our final breakout session of the day. So down the hallway, we'll have a breakout session for our care partners. If you are a care partner and want to learn some tips and tricks about being an effective care partner, that breakout session is down the hallway in the breakout room. In about 5 minutes, we'll go ahead and get started. We're going to do 2 sessions, a dance session with 2 left feet. We're going to have some choreographers do a presentation and show the benefits of staying active and dancing with Parkinson's disease. And then we also have a vocal exercise singing session as well. So we're gonna transition and swap, so give it about 2 or 3 minutes or so. So if you wanna be here for the art session, you're more than welcome to stay here. For care partners, if you wanna go down the hallway to learn more about being an effective care partner, it's straight down the hallway to your left.
I want to get a picture.
Oh,
of
sure.
your son.
Yeah, sure. Which one? Which right there? The one from the.
I was just gonna use the sign.
Oh, okay. Right here? Oh, there you go.
And can we also have one with just him?
And can you make sure the sign is?
Got it.
Thank you.
And you're doing a wonderful job of getting things going and everything.
Okay, good. Thank you.
So the instructor of the dancing session.
Yes.
Is here.
Yes, he's here.
He's coming in soon, the guy. Yeah, yeah.
Are you dancing with us too?
I'm with that.
Okay,
group.
good. Yeah.
So we
So she-
decide what we have to push back.
Yes, I'll fix all this for you guys.
Got it in your brain already.
Oh, it's no problem. I'll go ahead and move those chairs. Give me
No,
one.
I'm just pleased that you thought of it already.
Oh, well, we try to do something different, you know, try to change it up a little bit.
Oh, there's our famous leader right there.
Yeah, perfect.
Hello. The lady who knows.
There, right?
Look, I'm gonna push these chairs back.
Good, okay.
Yep, give me 1 second.
So we'll ask people to come up.
Oh, are you guys? It's, you're more than welcome to.
Yeah, I think it would be a good idea. Wait until we see how many people here first.
It's good. Okay.
I was thinking with Dan, so they're gonna move these chairs back.
Is that okay? She's the best one to ask. What's going on? We push chairs back? Oh, yeah, definitely.
Maybe we can.
Oh, no, I'm a speech therapist at Riverside. Yeah. They're the volunteers. They're the rock stars.
Can we vote this table right there?
If you're here for the art session, please feel free to take a seat. We're going to get started in about 5 minutes. So if you're here for the art session, please feel free to take a seat. We're in the process of transitioning. Give us about 5 minutes and we'll go ahead and get started.
I'm assuming you want to get on Yeah.
I think I'll stay together.
Yes. I thought that'd be great. You know, we'll do all that.
Everybody going outside? Yeah.
Oh.
What was it?
Actually, what we need to do is move that, which doesn't move probably. Does that move?
You don't have that issue with it, but you have to be.
It may not. You guys maybe do.
Yeah, we'll do it.
I guess we'll.
What is it?
Think over
Put it up?
here.
I think over here. Can I just see something? Because it did move.
I mean, there's.
No, it's.
Oh, there's boards. Oh, okay. Yeah, you're right. Sorry.
It's not gonna.
It's okay.
It's all good.
Are you ready?
I am
I'm
right.
going to introduce you and then we'll go ahead and get started. All right. We have made it to the end of the day. We are going to go ahead and get started with our final breakout session. Just a reminder to please complete the surveys that are on your tables. This helps us as we plan for future programs, knowing what you guys are interested in, knowing what you guys like. So please complete your surveys and leave them on the table before you leave.
Very good.
All right, we are going to go ahead and get started. So, as you may know, art-based therapies have been shown to increase socialization and may improve mood and cognitive-based benefits. Dance has shown the improvement of fluidity of movement and balance while providing aerobic activity, and song-based therapies for PD have been shown to improve voice quality, respiratory function, and swallow function. So we're excited to have this segment. We've done a lot of education today, and now we're excited to close it in with a little bit of fun. So we're excited to have Lisa Edwards from Riverside Healthcare Systems and Two Left Feet to give a demonstration for us today. So briefly, I'll introduce Lisa first. Lisa Edwards is a graduate of Edinburgh University of Pennsylvania, where she earned her Master's of Arts in Speech Language Pathology. Lisa holds a BS in music education with a concentration in voice. Lisa is a member of the American Speech Language Hearing Association, and an active member of the performing arts and choral communities with a passion for preventing injuries and fatigue and professional voice users. Lisa is a certified clinician in the Lee Silverman Voice Therapy Lab for treatment of Parkinson's disease and is part of the neuro treatment team at Riverside Outpatient Therapy. Additionally, Lisa, well, please welcome Lisa. Well, first we'll have 2 left beats, and then followed by 2 left beat, we'll have Lisa. My papers are all out of whack, so I apologize, but I'll have Rick from 2 left beat introduce himself and go ahead and get this session started, and then followed by that, we'll have Lisa from Riverside Outpatient.
Hello. Hi, my introduction is much shorter. I am 2 Left Beat Dance Studio. I do have a degree in history, by the way. That's it. Let me tell you a little bit about our program. Around 5 years ago, just before COVID, we, my girlfriend Lynn and I decided that we should start giving back to the community. So we started several programs. We worked with people with Parkinson's disease. We work with people with Alzheimer's. We also have taught children with autism to line dance. So that's how we got started with all of this. We did have to take a break, unfortunately, during COVID. And in that time, we did have quite an attrition rate as to the number of people coming. When we first started, we had about 8 to 10 couples participating in our program. And Leroy, who I'm going to introduce in a moment, and Kathy were the only 2 that originally came back. We now have added 2 more couples. Dancing is one of the most important things that you can do from a balance standpoint. I'm going to let Leroy address some of the benefits that he's found rather than me telling you what people have found, and then we'll do some dancing. Our classes are held on Wednesday afternoons at 3:30. They are free, and we dance for about an hour. We do a lot of different dances. We do the rumba. We do some Latin dancing. We do the bachata. We do the rumba, and we do the waltz. And we're going to demonstrate those dances today. If you're looking for perfection, you can leave right now. The idea is not to be perfect. The idea is to learn. And some of the people, Gary and Jan here just have been joined us a couple of weeks ago. Gary, and we have 2 Garys in this small group. Gary and Heidi joined us about 4 or 5 months ago, and Leroy and Kathy have been with us since the beginning of the program. So Leroy, if you'll just give her. Oh, Kathy, okay.
Well, one of the benefits I found is leg strength. And that comes from doing different kinds of steps. We go forwards and backwards and to the side, which we don't do a lot in normal walking, particularly backwards. I don't know if any of you tried to walk backwards on the sidewalks. We live in an area where the sidewalks are like this. It's quite a trick. And that also helps with the balance, because on some dances you make turns. And we don't usually do that in our everyday walking as often as we do in dancing. And you have to do it not just once, but you do it twice or 3 times in a quick order. And you can easily lose your balance. And that's been helping to me to maintain my balance. And arm movements. One of the dances we do is raising my hand, and my wife rolls underneath. And she keeps telling me to keep my hand up so I don't take off her head. Then there's always the social connection with the group and It's been really beneficial for Kathy and me as a couple. And it's a way to keep my mind and body together without saying you just got to go do this.
And I would say in that I'm the original two left feet. And if I can learn this after 5 years, anybody can learn it. But I think the important things, besides what Leroy told you, is that it's just fun for us. You know, sometimes living with Parkinson's can be frustrating, but going to dance class is always a joy. And the social part of it is a joy too. Being with people who understand what you're going through. And so it's one of those things in our lives that we hardly ever miss.
They cancel doctor's appointments.
No, just don't make them.
Okay, the first dance we're going to do, and I'm gonna have to adjust this for the volume, and I hope I don't blow you out of here, I don't think it will.
Just remember when you're watching us, we're doing this in a big studio, not in a little area like this.
And on a perfect dance floor. Carpets are not the best to dance on. First one we're gonna do is going to be a waltz. It is called the River Waltz. It can be danced to any waltz. We dance it to Someone Must Feel Like a Fool Tonight by Kenny Rogers.
Someone is a sheep. They're not right. Really, they hurt you.
Right.
Someone must be like a fool. The way they let you go. Someone is a sheep that died right. Really, they hurt you so. Now that you're here in my life, forget all your yesterday. Someone must be like a fool tonight for letting you sleep. When I see the moon shining in your eyes, feeling comes over. The warmth of your touch makes me realize just how lucky came. Surely he knows that he's sorry now. If you turn your love away, someone must be like a fool tonight.
Technology.
The line dance too.
Yes, this is also a line dance, which means this. Gary and Heidi and Gary and Jan have decided to dance this dance as individuals. They find it's a little bit easier, so they're actually doing it as a line dance. We're doing it as what's called a partner pattern dance, all the same thing. The next thing we're going to do is a rumba line dance, so it will be done individually.
But love's not burning with that same old glow. You're trying to win what you already won. You love her and you won't let her go. Well, buddy, this is my opinion. Sleep around the feet with the slow, slow dance. Oh, no, she's rolling on the floor night. If you love her, but you can't be sure. Take her on the street like she's not yours. She wants to feel like it's your first time. You gotta shower, shower. She's full of fantasy from every rhyme. I know what I would do. Sweet with a slow, slow dance. Oh, she's falling on the nights. But you can't be sure. Take her down, she's not yours. She's falling on the if you want love, but you can't be sure. Take her out and treat her like she's not yours. Sleep around feet with a slow, slow dance. Oh, she's falling on the needle dance. If you want love, but you can't be sure. Take her out and treat her like she's.
We do have some stage fright up here. On the point of all of this. I made a mistake too. The last dance, yes, it's not a lot of room like we have at the dance studio, and again, we do have a free floating wooden dance floor, which is a really great way to dance. We appreciate it when you're on call. The next we're going to do is bachata. It is a Latin dance. It is becoming very, very, very popular in this area, and it is a relatively easy dance to learn. And so we'll do a little bachata, and then we'll turn it over to Lisa with the resume from here to here. You're gonna recognize this song. They're taking a lot of songs that we're familiar with and turning them into different dances. You're gonna hear it to a different beat, but you'll all recognize this song. You just won't recognize the way it's being played, but it's been tailored so that it's great for the bachata.
When the night and the land is over, it's the night, and I know it's me and me. And you say, stand by me. And what I can say, it's a sad world. No lloraré, no lloraré. Oh, no lloraré, porque sé que tú sabes. That's fine, right here.
Oh.
We'll be sticking around for a few minutes. If you have any questions, if you're interested in our program, just come and get one of my cards. Wednesday afternoons, 3:30, we generally dance till 4:30 if we're not too tired. Sometimes we stop 4:15. And the fourth Wednesday of every month, I get my haircut, so we stop at 4. Lisa.
Oh, there we go.
All right, everyone, thank you so much for sticking around. That's gonna be a really tough act to follow. Good times, good oldies. All right. I'm Lisa Edwards. I'm a speech therapist at Riverside Outpatient Therapy. I'm actually at both of our new locations. Thank you so much for hanging around with us today. It's been a really cool day and it's great to be able to be here to tell you some exciting new news we have coming down. All right, so we had a little passion project / brain idea happening about August of last year. We decided that we wanted to find a way to incorporate more arts into our community with Riverside. And a couple of us got together and thought, we could do a choir, right? Yeah, what should we do? And Parkinson's came up. And I said, count me in, please, please, put me in, coach. it's my jam. So I've got a degree in music education. I was a performer. You can catch me on stage at Busch Gardens way back in the day, all that jazz. So we kind of put things together and we now have this lovely program happening. So group of people, there's a whole list of them that came together to bring this together, but the Martha W. Goodman Center has been so gracious to host us there, and help us bring us on our feet, or sitting. You can sit too, you don't have to stand. Right now, we're just kind of calling it the community sing-along for people living with Parkinson's. We're trying to find a catchy phrase, so if you get to be the winner to figure out what it is, that'd be great. All right, my previous career was in music education before I found the lovely world of speech pathology. So. All right, do you hear people saying, speak up, I can't hear you? Yeah, that's a good one. How about, what did you say? That's my favorite. I can't understand you. And then if you're coughing your face off, did it go down the wrong pipe? Yeah, how about that? Is that what we're hearing these days? All right, also, do you feel like you're having to repeat yourself? Do you feel like you're having to trip over your words, or you're choking or coughing when you're eating or drinking? Problems taking your pills if they're really tiny or if they're really big, doesn't matter. Also feeling out of breath when you're talking. Great. This is what we're doing singing. All right, so it creates better breath support for you. We're talking about diaphragmatic breathing. We're talking about all of the subsystems for voice. It helps us with articulatory precision, which is just a really fancy way of saying speaking more clearly. Exciting. And then increased amplitude for your voice, which just means a stronger, louder voice, which we notice a lot with our Parkinson's population. And then that good old masked face that we get, if people are saying, why are you so serious all the time? Okay. It improves attention and focus, which is a great thing to have. All of this helps with following our music. You know, it's really good for your brain. And you know what? You don't actually have to be able to read music to be part of this, I promise. It's a cognitively demanding activity. So it's really going to make your brain work. It's a nice little exercise. And also it's cross-hemispheric work. So it's one of those few things that in our daily life actually uses both sides of the brain at the same time. Pretty cool. All right, so we kept thinking like what makes singing so enjoyable for everybody? And this is kind of why we landed on singing as kind of our first jumping off point. So it's timeless. You know, everybody likes jamming, everybody likes singing, you know. Think about birthday parties and gatherings with friends. Yeah, it's something that, you know, it's rooted in cultures, it's rooted in kind of our daily life. And many people find singing to be a great outlet for them. Some people consider it like a nice stress relief. Others might find that it's kind of their safe haven, their place where they can kind of break out and relax and just be themselves. Okay, so why should you help us join this community sing-along? Why not? I mean, come on, give it a try. All right, so our goal is to keep your voice healthy and strong. And also, you're swallowing, because that's a big thing too. You get to meet new people. I mean, how many people want that interaction with other people that are experiencing some of the same things that they are? And also caregiver support. I keep hearing many, many caregivers say, can I just hang out with other caregivers for 40 minutes of my life? That'd be great. All right, so I did say you did not have to read music, I promise. That has been the first question that every one of my patients is asking is, do I have to like pull out the music theory book? No, please don't. No, you do not have to read music. You do not even have to consider yourself a good singer. If you enjoy singing, we want you, period. All right, so let's see. That second phrase was something that kind of hit home with me. You know, we're looking for people who want to be part of a group to share a similar goal. And that goal is that Parkinson's will not stop us from using our voices. From spreading music and cheer. Okay, yes, but not stop us using our voices is really the biggest thing. And no music experience necessary, my big caveat. We'll walk you through all of the songs that you'll be doing. Nice, friendly environment, super easy. We'll make it happen. Every skill level is all welcome. All right, our goal is to be using music from the Great American Songbook. Many of you have probably heard many tunes from this. This is they consider it the standards of the good old 20th century. We're talking, I think the earliest is like 1889, but it's really 1900s up through 1960 something. So it's all those really fun classics that everybody knows, everybody loves. They're super singable. And always end up as those little earworms. And each month, we're actually going to kind of change the idea. We're going to kind of theme it. So we'll have a couple songs that we do each month and then kind of flip over. Eventually, yes, we want to do a concert. Not right now, but that would be a really fun community goal for us. So Broadway musical theater, Hollywood film, you name it, it's on the docket. So we noticed that with Parkinson's disease, it's the idea that it kind of turns down that knob in your brain that allows you to be able to regulate how much energy and effort you're putting into something. And it affects your daily activities, you know? It could be the volume of your voice, how big of the steps you take, thank you to Lefty. Also, how clear you speak, how fast or slow your speech is. Maybe the pitch or tone of your voice. Some people say their voice is higher, their voice is lower, their voice is kind of squished, they kind of lost that range. All of those different things can be affected with Parkinson's. Also, it can affect memory, thinking, concentration. All of those things might keep you from driving too. So that's why we want to continue to exercise that brain along with that voice. All right, number one goal, have fun. Promise. Number one goal, have fun. It's recommended exercises that come from multiple areas of speech and multiple areas of music. We're using parts and pieces of LSVT Loud. We're using parts and pieces of Speak Out, Parkinson's Voice Project. We're using parts and pieces of Resonant Voice Therapy, and just about everything else in the musical theater world. So, and the voice world. We're talking about all the subsystems, good breathing, diaphragmatic support. It's awesome. All right. Our biggest thing is creating that camaraderie with everybody. We want everybody to feel comfortable and welcome and part of the team. We also found that there are not any live local choirs in this area. The closest live one is in Baltimore. So we decided that we were going to take the bite bait and just go for it. And it's been such an incredible journey. The response we've gotten already has been, sign me up, when does it start? You know, it's been really cool. So I've got sign up sheets that I'll have on clipboards with really fun little pens, because that's totally me. And all we need is your name, phone number, email. Our idea is that we're hoping to get it off the ground starting either end of April or beginning of May. We've got 2 grants that we're in the process of working through right now for some funding for our song books and all that good stuff. It will be hosted at the Martha W. Goodson Center in McClaw Circle in Williamsburg to start. We're looking at twice a month. I believe we're looking at like the second Tuesday of the month-ish and 4th Tuesday of the month. And the idea would be kind of midday, but it's going to be flexible. We're going to basically see where everybody can be there and when people can be there, because really we want to do this for you. That's why we're doing this. So be on the lookout for information. If you give me your name and phone number, you will be the first to know what's happening. So and get your name and phone number down on those sign-up sheets and we'll get you rocking and rolling. And then thank you for our partnership between Martha W. Goodson Center and Riverside Therapy Group. And can't wait to make some music with you guys soon.
If you'd like to have any questions for 2 Left Feet or for our speech pathologist?
Where's the sign up sheet?
I got it right here.
I don't need, my question is this open to caregivers?
Absolutely.
Good, because he doesn't run.
Absolutely. Yeah, that was actually something we were thinking about to start is, you know, if we limit it to only patients, then who's going to get you there? Also, if we limit it to just patients, then what happens to that caregiver support as well? So we're definitely opening it to whoever wants to be there, whoever wants to join. If you want to bring a friend with you, you're more than welcome. We're hoping to have some partnership with William and Mary students as well. We've gotten some irons in the fire there to have them come over and help out. So we feel supported and loved. It's a really cool community, and I'm finding more and more people that are willing to bend over backwards for you guys. Anything else?
I just want to say that the 2 Left Feet and then the Parkinson choir, I think is phenomenal. I do, it's all community camaraderie and like movement and independence and having fun. And that's one thing that I have discovered is that a lot of people, when they get that diagnosis of Parkinson's, they say life is over. I have to quit my job. I just, just stay home because this is it. It's a death sentence, or, like you're in prison. But it doesn't have to be that way. In fact, when you get that diagnosis of Parkinson, keep working, keep moving, keep doing stuff, because that's what's actually going to help you. And so having the 2 left feet, I think that is phenomenal. And I think the choir, I think that's so wonderful. We're so lucky to have these 2 great resources. But that's the thing, is that the more we move, the more we do, we're improving our self-esteem, we're, getting a boost of, good mental health. And it just shows that life is, it doesn't have to be defined by Parkinson's. We have Parkinson's, but we can still do things.
All right, so we are at the conclusion of our program today. How do we think the conference went? Round of applause on how you guys went today. Good. Well, hopefully this can be an annual thing to be determined. But we appreciate you guys coming out today. Just the last couple of minute housekeeping rules. Please fill out the survey that is located on your tables. Please feel free to leave on the table and we'll collect them following the presentation today. I want to thank all of our presenters for taking the time out of your Saturday to be here with us today. Thank you for braving the weather. Now it's sunny outside, but we appreciate you guys if you traveled from far. We wish you a safe drive home. We want to thank our sponsors, our gold sponsor, Supernus, our silver sponsor, Medtronic, and our bronze sponsors, Insightec, AbbVie, and Amneal. And then finally, June 8th is our Optimism Walk in Williamsburg, Virginia. And please stay tuned for more updates and information on that. Part of that walk helps us fund programs like this today. So it will be in Williamsburg at the Warhol Sports Complex on June 8th. So we hope to see you guys back in the same city in a couple of months to raise some funds to continue to support our support groups, our financial support program, everything that we're trying to do to be able to support you guys in the PD community. So thank you so much for being here today. I'm not sure if the care partner breakout session is completely done yet. You guys are more welcome to stay here until they're done, but please leave your screws on the table, and thank you so much for coming today.